appreciate all of you joining us in person, and for those of us who are or for those joining us online. My name is Jeff Coots. I have the pleasure of welcoming you all here to John Jay College of Criminal Justice on behalf of Carol Mason, our president, and Anthony Carpy, our associate provost and dean of research. We're happy to have you in our student dining hall here today, which is a nice room full of windows so that we can think broadly and have some big ideas and big conversations today. A special thanks to the team at Data Collaborative for Justice, Mike Raquel and Crystal Rodriguez and Sarah Monahan, who helped us organize this event and are handling most of the online experience, which I am too much of a light-eyed to manage. So I appreciate all the extra support that we're getting and all the work that went into organizing. Our team at P2PH, especially this wonderful booklet that my colleagues put together. Very pleased to see all the great guests that they brought together for the day. Tiffany Sloan, who's our project manager. Samantha Ballack, who was you'll see both of them later today. They're moderating a couple of the panels along with Crystal from SJ. And then a couple of our newer additions, our research assistants. I love to hire from within John Jay College. So being here is one of our best recruiting opportunities. We have Rafaela and Cian and Hope, who you saw on your way in, probably gave you your booklet that I was referencing there earlier. So thanks to them. Those who weren't able to join us in person today, but I'm hoping are already online. Richard Shiola is our health policy fellow. He runs health justice strategies up in Boston. And Tracy Gardner, who after many years of working at Legal Action Center, had a brief stint in the governor's office, but recently moved over to lead the Black Harm Reduction Network. Her leadership in our cross-sector advocacy group over the past couple of years, and her thought leadership in helping us organize this event, and in helping me get connected with Dr. Wright, who's going to come in and share some words with us in a bit. So my job is to set the table, but before that, a couple of housekeeping items. We'll have food out here throughout the day. Feel free to get up and grab a cup of coffee in between the speakers and everything, or have some food as well. We'll have lunch here later. There's some extra tables over on the other side of the dining hall that we'll be able to take advantage of. It's not quite warm enough for us to go outside, but if you've got a nice jacket, there's some tables and chairs out there as well. The restrooms are right back out where you all checked in. And I am mostly a lot of have come to love QR codes. So the way that we're going to run Q&A for this is on each panel, there's a QR code, and that brings you to a link where you can submit your questions to the moderator. And so rather than us having folks line up at a microphone, we're going to handle the Q&A through our moderator there. And for those of you who are joining us online, at the beginning of each panel, we'll drop a link into the panel, and you'll be able to use that same link or the link to get to the same web page to put your question in. So part of my table setting conversation for this is, why are we all here today? Why are we here talking about this issue of public health role in the criminal justice system? And why do we want to have this conversation now? Why is this the right time for this conversation? And I think it's important to recognize that this is one of many conversations in this space, not just in this physical space, because at an academic institution like John Jay, we're having a lot of conversations about policy and practice and the impact that research can have on it. But that there's a lot of conversations happening throughout the city that are directly, if not indirectly, connected to this conversation. Just at the college today, there's another conference going on about gun violence and the role that prosecutors and other court-based stakeholders and other city stakeholders can have on public safety. There's another gun violence conference happening across town that's put on by the Mayor's Office of Criminal Justice. There will be more conversations about how we better deliver care to some of our most vulnerable community members, some of whom will come into contact with the criminal justice system. But on the larger side, we're really having a conversation about our social contract as New Yorkers. And what are our rights and obligations within that contract that we share with each other? And there's some element of government involvement in that, but mostly these are agreements that we make with each other, with our family members, with our coworkers, with our community members, with the people that we pass on our commute. And one of the things I want to encourage us to think about throughout the day today is that as part of our movement throughout the city, as part of our conversations with each other, that one of the most important things that we have to come back to on a regular basis is to not just recognize, but respond to the humanity that we see in those around us. And that can get lost sometimes, and particularly in academic conversations. So welcome you all to an academic institution. Let's not get too lofty in our conversations. Let's be mindful about the words that we use to describe people, the way that we talk about certain behaviors. Because when we talk about this intersection of behavioral health and criminal justice, one of the questions that we are posing to each other and to ourselves is, at what point are we willing to tarnish our own humanity by resorting to shackles and cages as a way to respond to the challenges that we see in our community and the challenging behaviors that some of our community members present? And so it's not an easy conversation for us to have. It's a welcome conversation for us to have, I think, in this moment when there are other conversations happening where they might try to dehumanize certain members of our community. And I think the other challenge with this conversation is that it is a really big conversation. There are a lot of moving pieces here. There are hundreds of agencies working in this space, dozens of government agencies, but hundreds of nonprofit and private organizations that provide services directly to the clients that we're going to discuss today, the individuals that we're going to discuss today. And the scale of that problem, the scale of the conversation can be overwhelming. It was one of the challenges we had when we first started talking about this event. How do we wrap our hands around this? How do we wrap our heads around this so that we can present a coherent narrative to you all today? And one of the ways we did that is we're not going to try to talk about everything, right? We're going to take a few small bites out of this apple today. And the way that we've tried to organize it is something that we try to do through the group that I work with here called From Punishment to Public Health. Probably should have introduced that a little bit, right? Which is where we try to apply a public health lens to issues of public safety, community safety, housing, mental health, substance use services. And one of the ways that we've done that in years past, and not just here at John Jay, but in the city, if you look back at the action plan that came out of the Behavioral Health and Criminal Justice Task Force in 2014, right? They used something called the sequential intercept model. And the advantage of using that sequential intercept model, which is something that was borrowed from a way to analyze emergency room utilization. What can we do at different steps before we put somebody into inpatient care? And so by using this model of saying, okay, what happens at phase of arrest? What happens in the court system? Then what's happening in the jail? And then what's happening in the prison? Then what happens on reentry? And what are we doing back in the community? So even there, I've given you 5 or 6 intercepts, right? I only have 3 panels for you today. But that helps us organize it. And it keeps us from falling into something that we've done in the past when we have a longer event, a 2 or 3 day event, which I don't know if I have the energy for these days. But where we had 1 panel on mental health, 1 panel on housing, 1 panel on substance use, 1 panel on reentry, 1 panel on probation. And the challenge there is most of what we end up talking about is we can't just talk about that one thing. We've got to talk about the intersection of those things. And our clients don't show up just as somebody with substance use needs. They show up as somebody with housing insecurity and challenge in accessing mental health services. So the way that we've organized this piece for you today is to say, what are some of the innovations that we see in the courts? And I'll say, even before I get to that, one of the things we're trying to recognize with our presentation with you all today is that we're not at the beginning of this conversation, right? As I mentioned, there was this action plan that came out in 2014, and some significant investments came out of that action plan. That's where we got the funding allocated for jail-involved supportive housing, right? Justice-involved supportive housing, where we were able to overcome some of the federal regulations on supportive housing access. Because at the time, if you went to jail for more than 30 days, once you came out on that 31st day, you were no longer considered homeless. And so the city had to say, that's kind of a silly policy. We're going to put some city money behind providing supportive housing to those with severe mental illness and housing disability, right? So there are pieces that have been put in place over the years. We still find ourselves in the midst of a media cycle where there are questions about how the rise in stabbings are related to mental illness. The author of that article admitting that there is no evidence that shows this. There was one recent stabbing that we know about, but then it's the stabbings are more than the shootings now. And is this a question of mental illness? That's the question that is posed to the larger audience that is consuming what is our public radio journalism out there. So that's part of the narrative that we have to be able to confront you. And part of what we're trying to present to you all is we've come a long way. This isn't a new conversation. We've made investments along the way. And there are some new things happening as well that you might not be fully aware of. And so we want to present both the context of where we've been, where we are now, and where we're trying to go. And in each of those conversations, I ask you to try to engage in it as best you can. So we have one panel on the courts. We have another panel on jail and prison and incarceration, the health disparities and health needs, and some of the programs that we've developed over the years to respond to some of those needs. And then our third panel of the day, which I know I'll lose some of you, but I hope that you join us for lunch and then you join us for the third panel of the day, because that is our most hopeful panel, where we don't have people in shackle cages, where we have people in the community and we're saying, here are our best strategies to not resort to the criminal justice system. We have strategies to prevent people from getting involved in the front end of the system. And let's think about how we can build up on those pieces. So 3 more requests I will ask of you in our time here today. One is, as best you can, be present. You made the trek from Columbus Circle along the cold 59th Street Avenue with the wind and tunnel that it is. Be here, be present with us. Use the coffee break, not just to check your email, but to chat with somebody you haven't seen in a while, or introduce yourself to somebody you haven't met before. Be kind. Be kind to yourselves. It's okay if you are not fully versed in all the things that we're talking about today. We're going to do our best to avoid acronyms. Be kind to each other. Please be kind to my panelists. They put a lot of work into this. And mostly, and this should seem the easiest one, but I'll come back to, be human. Right? Center yourself in that humanity that you bring here, and think about the ways that you want to bring that to others. So those are my 3 charges for the day. I also have the honor of introducing Dr. Gene Wright, and I had a great chance to have a couple of quick conversations with him about how we shape this big narrative, how we shape this big conversation. And we are really lucky to have this individual who came up on I-95 from Philadelphia to join us, where he served as the Deputy Commissioner of the Department of Behavioral Health and Intellectual Disability Services. And in that work was really intentional about how to make sure that he wasn't leaving justice of all populations out of that conversation. So I hope you will join me in welcoming Dr. Wright and enjoying the words that he has to share with us today.
Good morning, everyone. How are you?
Morning.
Oh, that means really good. I'm going to ask 4 times. I'm just going to ask one more time. How are you this morning?
Well,
So let me say good morning. Can you hear me okay?
yes.
Oh, they responded. Great. So I'm a preacher's kid, so I do want to hear back from you. All right. So a couple of things. Thank you, Jeff. Really important how you said the table for why we're here today. I'm so glad that you all took the time to come out. I want to thank the Data Collaborative for Justice for John Jay, and from punishment to public health. What a fabulous way to really do the work. Public health is so important, and I've been doing it for 25 years, believe it or not. And I love what you said in terms about being human and being present. I think one of the challenges that comes with the work that we do, the populations that we serve, is that too often the people who are not doing the work that we do and serving the people that we serve often see the folks as invisible. They don't see them at all. And I think one of the challenges with that is when you're constantly bringing up the challenges and the problems and the issues that we all work towards, people start identifying individuals as those things. As a clinical and forensic psychologist by training, I can tell you that we are very specific about the language that we use. We don't label things. As an example, a person is diagnosed with schizophrenia. They're not a schizophrenic, right? You say, oh, that's a play on words. No, it's not. It's inhuman, right? It's understanding who and what we're dealing with. And so one of the things I'd like to share with you in terms of how we have a conversation with people that are not in this room, with people who do not do what you do, that do not serve who you serve. How do you have a conversation? That's something that I wanted to touch on this morning as I go through some of my remarks and give a couple of examples. Because it's so easy for the people we're talking to, trying to convince somebody of something that they don't want to believe. Have you ever tried to do that? Have you ever had a conversation with someone about something you feel strongly about? You really want them to see your point of view so that they can get on board with you and tow with you and roll with you and push with you. And you're trying to convince them of something that they don't want to believe, that they don't want to hear. That is often what you may find when you're working with individuals that are in the justice system, the criminal justice system, right? Is that people don't really want to hear the story, but you got to tell the stories. Everyone has a narrative. Every person we work with has a narrative. And so I'll share with you a little bit about mine as an example. So I knew I was going to be a servant leader at age 12. My staff, you'll have to bear with me. You've heard this story before. My parents raised me and my siblings to be servant leaders. Now, what does that mean? That means at 12, I didn't know that I was going to be a clinical and forensic psychologist, but I knew I was going to serve in some capacity in the community. I didn't know what it looked like. I didn't know what it meant. And so I just watched as they served. And then I said, oh, and I found my niche. I have 2 older brothers and a younger sister. They all serve in the community. They all do something different than what I do. And so I really started thinking about the compassion that it takes to do what you do and to work in the spaces that you work. And what are the challenges? As an example, for Philadelphia, I did a lot of work. And one of the things I did was I built a division called the Division Behavioral Health and Justice Division. And it was one of the first divisions that focused on criminal justice in Philadelphia. There's a lot of different organizations that do a lot of different things similar, but not under the guise of the behavioral health system, under public behavioral health. And the reason we did that is because the commissioner at the time asked me 2 questions. He said, 1, what is it that we're missing in our service as behavioral health specialists, but also as the behavioral health department? Here, you guys call it mental hygiene. That's fine. And so I told him, I says, well, the one thing is that we're not focused on individuals who are returning to the community. I said, what do you mean? I said, people who are incarcerated and or psychiatrically hospitalized, because the justice system that I know is both. Now we're focused today on the criminal legal system, but understand many of the people we serve cross into both systems, right? And that's why when you go to things like the Soze Foundation and you go to some of those conferences, you get those nice bags that say mental illness is not a crime, right? Somebody left on the F train this week because of the verdict that came down. Mental illness is not a crime, So we have to have different ways of messaging as opposed to just trying to strong arm people into believing what we believe to serve like we serve. And so the second thing I told that commissioner was we have to be prepared, not just for people who are returning to the community, but we have to be prepared to make sure that they have all the entitlements that every single person who is not in the justice system has. As an example, heard the term reentry, right? How many times have you heard the term reentry? Everybody wants to focus on reentry. I'm not concerned about reentry. You know how easy it is to re-enter the community? All you need are discharge papers. You have a release date and you're back in the community. We focus on getting GEDs. Yes, it's great. We focus on getting license or ID. That's great. What about reintegration into the community? Reentering is a discharge. It is a release. Reintegration is a surrounding. It's putting your arms around people who are reentering the community. This is not a play on words. How you use your language and how you talk to people about the work you do and the value of a public behavioral health focus is so very important. Another example, when we were trying to convince the powers that be to support and put more money into reentry and reintegration, one of the programs we came up with was fathers and children together. What we did was we took children of incarcerated parents up to the prisons to visit their parents, sometimes grandparents, because there were multiple generations behind the walls. That program would not get the support that we wanted it to get when we kept focusing on making sure that incarcerated men and women had access to their children. Believe it or not, nobody cared. But when we said every child deserves an opportunity to connect with their parent, suddenly both sides of the aisle were supportive. Did we change the program? No. We changed the language of how we presented the program and how we presented to people who were naysayers, who were, unfortunately, were not like you in this room, who did not see the value in doing anything for the incarcerated person. They saw the value in the person's child, who everyone said, yes, children need access to the parents. And so after that, they gave us permission to make sure that those parents also had access to the school system so that they could weigh in on disciplinary issues. They could weigh in on grades and things that the filial parent or the primary caregiver may have been saying ad nauseum. But you know how that is. Some of you that are parents in the room, you've said it 500 times. But when the teacher or the coach or your cousin or your aunt or your mother says it, then it's a little different. But when you say it, it's not the same. So we simply change the language and we change the message. It's important how we say what we say and who we say it to, the way that we really want to understand why people don't get on board with what we are trying to do. Another thing, the elevator speech. Have you ever given an elevator speech? What is an elevator speech? You have between floor 1 and floor 3 to convince somebody of something. That's the elevator speech. With this huge undertaking that we're doing, how can you tell somebody the importance of supporting folks who are returning back to the community from incarceration in 3 floors? What is your message? I would suggest that you don't start with your resume about who you are and what you do and why it's so fantastic, because you are fantastic. I would suggest you start with your why. Why do you do what you do? People are very interested in a narrative. People are very interested in a story. Think about the movies that you like. If you don't see yourself in the plot and the characters, how long do you stay at the movie? What about the books you read? When you're reading a book, if it just really captures your attention, why is that? You relate to the characters. You relate to the plot. You are in the pages that you're reading. That's how you tell the story of the people we serve. And you give them an opportunity to share their narrative. Everybody in this room has a narrative. The challenges that we're facing in 2024, really quickly heading to 2025, I think we need to tell a better story. When I say better, it's not from a judgment standpoint. It's like understanding what the audience is trying to understand about your story, about the story of the people that you serve. What are the salient points that you want to get across? Even today, with this conference, what do you want to walk out of here with? What do you want to have learned from your colleagues and from the people that we serve? So one of the things that I would suggest is that we stop having meetings in boardrooms and talk about what we can do to solve the problems of the people we serve. And I would say, even though we want to hear the voices of the people we serve, don't invite them to the boardroom. I would suggest that you invite yourself to where they are. I'm really bold like that. I find out where they are, and it's like, oh, you guys are having a meeting. And I come, and I meet them sometimes on the corner in Philadelphia. I hadn't found the corner in New York yet, but you all will help me. And I show up. Because I learned a long time ago, if I step aside over and open a chair at the boardroom table, nobody's coming to that. And if they do come, they don't feel comfortable because you didn't make them comfortable. I didn't make them comfortable. But when you go to where a person lives, and when you go to where a person thrives or wants to thrive, and you ask the question differently now, it's no longer an elevator speech. Now it's a one-to-one, it's a conversation about what do you need? And how can I best help? How can I serve? It's taking a one-down position for whatever position you have and simply saying, I want to be human with you. I don't know your life. I don't know all about it. I don't want to make any assumptions of how you got here. What I do want is to learn how I can best serve. That's a different conversation. Now it's an invitation. Another thing that I learned during this process, even before coming to New York, was understanding what the right questions are, especially when you're dealing with individuals that have not only histories of involvement in the legal system, but also serious mental illness, substance use disorder, and a combination of all kinds of them. And again, the people in this room probably don't ask this question, but we need to correct people who do. Stop asking people what's wrong with them. Stop asking people what's wrong with them. There's nothing wrong with any of us. The question is, what happened? What happened? When you ask what happened, you're making an assumption that has served me well in my 25 years of clinical practice. And that is most all of us have had some experience of trauma. Your trauma may not look like my trauma, and this is not a contest. But I need to ask the right question so that I can give you permission to create your own safe or brave space. I cannot say this is a safe space. You ever heard people say that this is a safe space? I'm making some assumptions. And you're looking at me like, well, how do I know if it's a safe space? I don't know you. No, what you do is when you become human and you actually ask people what they need, what they want, what their experiences have been, you're giving them the ability to create their own safe space with you, in the room with you. That is the challenge that I would like to really put out there for today. And also, as we use things like the sequential answer, I'm glad you brought that up, Jeff. I actually served 25 years with Patricia Griffin, who's one of the authors of the sequential answer model. We're still close colleagues and friends. The thing about that model that's important to know is that it came out of time and experience of working with the very people that we serve. It wasn't purely an academic exercise. It was built upon the knowledge of working with people and understanding what those challenges are. And so I ask each of you today, what is your why? You can answer. Yeah, you can answer. What is your why? Oh. To help. What does that look like? What does that look like, helping? Anyone, what does helping look like?
Being there.
Being there. Yes, yes.
Not just
Judgmental. What we call as clinicians, unconditional positive regard. For you parents in the room, that means you may not love what they did, but you love the child. Okay, so how do we use that in our work? This is the challenge, I think, for us. Sometimes we're so close to it, and we're so sincere and committed and passionate about what we do and what we want to do, that sometimes we inadvertently put our values onto other people, even well-meaning. That is the challenge. How do I understand your values so that you can share with me how I can best serve you? That is how we can get the work done, but it's also how we can change the narrative for the people who aren't in the room, who don't see the people we serve as human as we see the people we serve. Those are the challenges. And so I want to leave you with just a couple more things. How am I doing on time, Jeff? 10 minutes. That's way too much time, Jeff. So, a couple of things that DOHMH is focused on. And you're very fortunate today because you're going to have Trevor later on the panel. Trevor, where are you, Trevor?
Right.
There he is over there. Trevor's fabulous. You're going to love it. So, the important thing is we want to partner with you, the health department. I've been here 7 months, and I've learned so much from my staff, from people around the city, agencies. Met a new friend this morning who we're going to connect and get some things done. But I really want to give you an open invitation to contact me. And all my staff know that I'm serious about that. When I say my door is open, it really is. That means the phone is open too. The email is open. Reach out to me. But these are some of the things that I'd like to work with you. We have some key opportunities that are coming up that we want to work with you. We all know that housing is a challenge. Is that pretty established here? Jeff and I talked about this earlier in terms of it's hard to live in New York City, no matter how much money you make. Right? What are you doing when you're just returning to the community? It's hard, right? So we're looking at justice impacted supportive housing, which you guys are probably familiar with, probably more familiar than I am. And we want to provide housing services to individuals with histories of justice involvement, focusing on helping them reintegrate. That's the key word, not reenter, reintegrate into society and prevent homelessness. Now, when we say prevent homelessness, do you really believe that's possible? Or do we just throw these words out there because it's the right thing to say? It's like when you're trying to convince somebody of something. If you don't believe it, how successful do you think you will be at convincing another person to believe that you don't believe? It's not possible. So you have to really, really believe what you're doing. Now, me, I don't try to get buy-in from anybody. Why? Because I'm not selling anything. I'm looking for investors. I really am. Who wants to invest, not just in the work that we do, but in the people that we serve? And what does that look like? I can tell you what it looks like from my point of view. When Miller versus Alabama came down, and then the Montgomery decision came down, where it made it unconstitutional to sentence children to life without the possibility of parole, over 563 of those individuals were from Pennsylvania. The vast majority of those individuals were from Philadelphia. I have worked with that population for more than 10 years before they got out, and the 12 years since that decision. Actually met Mr. Montgomery a few months ago. Less than 1% of that population has recidivated in any kind of way, or had any new charge of any kind. They go all over the world campaigning. The campaign for the fair sentencing of youth. Look it up, Google it, campaign for the fair sentencing of youth. These are formerly incarcerated persons who were given a death sentence as children. What changed that? What turned that around? It was that the Supreme Court at the time believed the science of the developing child brain. Science is useful because those Supreme Court justices who voted that down, it no longer, it's not unconstitutional to sentence a child to life without the possibility of parole. Understood what the science was saying about the developing brain, even into your 20s. So that what you did at 13, 14, or 15, you're not thinking the same way when you're 25, 30, and 45. Make sense to you? So those are concrete examples of a person and people believing in something, using science and data to drive it, and then making sure that you follow it all the way through until a decision is made so that people have the same opportunity and quality of life. We don't have time to talk about, was the punishment fair or unfair? That's not what we're talking about. We're talking about if you give a person an opportunity to embrace life, what will they do with it? And that's what you guys in this room do. You give every client that you serve an opportunity to embrace life. That's why you have to keep believing. And what does that mean? It means that we have to keep pushing on the housing piece. It means that we have to keep pushing to make sure that they have access to all the entitlements that every other citizen in New York has access to. We have to make sure that we have, for individuals who don't know about 988, know about 988, right? That is something that is across the whole country. I must say that Philadelphia was the first city, large city, to implement 988 immediately when it became law. Just throwing it out there. But because I'm in New York now, I am even more motivated to make sure that everything that we can do for New Yorkers happens while we still have life and breath in our bodies to do it. Let's not worry about the next 4 years. And I know a lot of people are worried about the next 4 years. What we need to worry about is nothing. Why? Because I think it was Will Rogers that said, worrying is like paying on a debt that may never come due. So why worry? Just do. Just work. Stay committed. Stay focused. Understand your why, because that's so very, very important. When everything else starts to look like it's going to fall apart, if you stay connected to your why, then you show up. And that's what I've experienced at the Department of Health. That's what I've experienced with all the staff that I've worked with all the hard times, all the changes, all the ups and downs that happen that none of us have any control over. Why do you show up every day? Why do you keep coming to work? Is it work? Do you love what you do? I was sharing with my colleagues, I've been doing this for 26 years. I've never worked a day in my life. Oh, that's corny. He's just made it up. I've never worked a day in my life. Remember, I knew I was going to be a servant leader at age 12. And everything that has come since then has been positioning me and preparing me for the fact that your life is dedicated to service. Now, there's some things you need to let go, like you're not going to be wealthy. So let that go. So rich.
Okay.
So rich. And I'm so rich that I can afford to give everything that's been given to me to everyone that I serve. That's my humanity, that's my love, my respect, and my determination that because you do not know you have a voice, I will speak for you as you give me permission until you can speak for yourself. I will go for you to places you can't go until you feel you can go. I will fight for you until you believe you can fight for yourself. That is what I believe drove you here this morning. You're in the fight. You're not intimidated. You're not scared, and you're not worried. There's so many other things you could do. There's so many other places you could have been today, and yet you chose to come here. Thank you. Thank you. Thank you. Thank you.
Good morning. Morning. Can you hear me? My name is Rafaela Elmi. I'm a research assistant from Punishment to Public Health and a student in John Jay's Forensic Mental Health Counseling Program. I'm happy to introduce our next speaker, Elizabeth Johnson. It's a pleasure to have Elizabeth with us today. She is a data scientist at the Clean Slate Initiative. Her impressive experience with criminal justice initiatives, particularly her contributions to the Data Collaborative for Justice and her work with New York City Mayor's Office of Criminal Justice, underscores her expertise in applying data-driven strategies to support meaningful policy change. We're looking forward to hearing her insights into the complexities of New York's criminal justice system. Please join me in giving Elizabeth a warm welcome.
Hello, everyone. I just need to set up the computer, so it might be a minute, but I just want to say thank you for having me here. I know it is a little bit early, but I am going to talk about data, so bear with me. Thank you. Okay, look. Okay, perfect. Yeah, so my name is Elizabeth Johnson, and I'm a data scientist that worked with the Data Collaborative for Justice to publish the New York City Jail Population Tracker. This is a dashboard that reports real-time data from the Department of Corrections on the people currently incarcerated on Rikers Island. And we have data that goes back all the way to 2016. So we created this tool to track the progress on the effort to close Rikers Island by the legally mandated deadline of August 2027. And for those of you unfamiliar with the effort, back in 2017, former Mayor Bill de Blasio pledged to shut down all the facilities on Rikers Island. This has actually happened 2 times prior. City officials have attempted to close the jail complexes on Rikers Island. And this mainly stems from the historic, violent, inhumane, and unconstitutional conditions in the jail complexes that not only puts incarcerated folks in immediate danger, but also leaves people with long-lasting trauma, mental health issues, physical health issues, among other things. And so today I want to walk you through the tool. There's so much on this tool that I'm not going to get to today. So I do advise that you do have your own time to explore this, to learn more about the effort to close Rikers Island. Mike Rimpel worked so hard to gather so much information here on the homepage, explaining the problem and the solution that is proposed to end these inhumane conditions, as well as tactics that we believe at the Data Collaborative for Justice are effective tools to further reduce the jail population on the island. But I am going to talk a little bit about the historical trends and the current state of the jail population. I'm also going to talk about disparities both by race, by gender, and I want to also showcase some statistics on the population with mental health designation. Okay. So I want to kind of set the scene. In the last 30 days, there were 6,661 people incarcerated on Rikers Island. And why is that important? I kind of skipped over a really big part of the story here. So what is going to happen after we close Rikers Island? We are actually transitioning to a borough-based jail system so that all boroughs in New York City, except for Staten Island, will have a jail facility located close to the court systems. The big problem here is that the maximum capacity currently for those 4 jails is 4,200 people. So we are about 2,200 people over that target number. And unfortunately, we are continuing to see increases month over month and year over year in our jail population. Compared to the last 30-day period, we've actually seen an increase of about 66 people. And compared to 1 year ago, we're seeing almost an increase of 630 people. If you scroll down on the tool, you can actually kind of see this trend on a timeline going all the way back to June 2016, which is the earliest date of data that we have collected in our data repository. We've also combined this graph with a bunch of policy events and world events. And so I kind of want to help paint the picture of what has been happening over the last 8 years in the jail systems. So back in 2016, that was under the de Blasio administration. We were close to about a 10,000 population count for the people in custody of the Department of Correction. Now, as you can see, we aggressively decreased that number all the way up to the beginning of the COVID-19 pandemic, where we hit an all-time low of about 3,800 people, which is this kind of elbow in the graph down here. And so this all-time low was for many reasons, because we were investing in alternatives and diversion tactics all the way throughout the de Blasio administration. And you can see that we have this orange vertical line here is raise the age implementation, followed by bail reform implementation. However, right after the emergency order for COVID-19, the Department of Corrections discharged people due to safety concerns in custody, and that is kind of what also helped us get that 3,800 number. However, what else happened after the COVID-19 pandemic? Courts were forced to go virtual, things started slowing down, and the length of stay for people currently in custody started increasing. And we started to kind of see this backlog of people in custody, which caused our numbers to rise month over month, and basically making the trajectory of our jail population turn in the wrong direction. And that is what we can see to the right of this kind of elbow in the graph. Now we're under a new administration, the Adams administration, and we're currently seeing steady increases, getting further and further away from that 4,200 mark that we need to see in order to safely close the jail complexes and transition into our borough-based jail system. Another thing that we did was to break down, sorry, this is not big enough for on the screen, but to break down the population further into population statuses. And now this variable is something that the Data Collaborative for Justice created using a variable in the source data, which comes from the Department of Corrections called Inmate Status Code. And this buckets people in custody into 4 main buckets: people who are serving pretrial detention, people who are serving due to a parole violation, a jail sentence, or people who are awaiting transfer to upstate prisons to serve their prison sentences. And then everyone else who doesn't fall into that group are bucketed as additional groups, and that's a very small percentage of the overall population. And so consistently over the 8-year period of data collection, we can see that pretrial detention remains the largest subpopulation of people in custody by far. And so in the last 30 days alone, that population could actually account for 84% of the people in custody. That is about 5,600 people. So there's only about like 1,000 people, give or take, in the other groups. And I think it's important to call out that this group is nearly 10 times larger than the second largest population status group, which would be jail sentencing. I think that this graphic is also really compelling. So you can actually toggle out the pretrial detention population because it skews the graphic so much because it's so big, and kind of focus on these smaller population groups. And one thing that I want to call out here is this red line. So that is the number of people serving time due to a parole violation. And we can kind of see that the historical trends in these graphs start to really change about mid-2020 actually, and further into the middle of 2021. And this is mainly due to the signing of the Less is More Act in September of 2021. And I just want to emphasize that this shows us that thoughtful policy, when implemented correctly, can really help us further reduce the jail population on Rikers Island. There's so much more on this tab. I'm not going to have time to go into it. But if you are interested in investigating the actual trends at a daily level across the months that we have in our data set, you can do so using this month-to-month comparison tool. And the last plug that I'll give for this section of the dashboard is actually a downloadable data table. So one of the biggest problems that we've faced creating this tool is that this data is not available. The way that the Department of Corrections uploads this to the New York City Open Data Portal is that it's a daily snapshot. So right now, it's actually yesterday's data, which is on the New York City Open Data Portal, but there's no other data on the people who are currently or were incarcerated. And so thanks to other institutions in New York and my colleague Richie, we've created this data warehouse that collects this data every day. And we thought that it was really important to share that with the public. So you can come down to this section and you can actually download a file of the daily population as a total, but also across all the different variables in the data set, which would include race, gender, mental health designation, so on and so forth. So if you're interested in doing your own analyses, I do advise you to go and check that section out. Okay, so now I'm going to talk a little bit about racial and gender disparities. But before I do so, I need to kind of go through some caveats in the data that is reported by the Department of Corrections. In this section, we're going to focus on three main variables: race, gender, and mental health designation. So the publicly available DOC data only reports race. It does not report ethnicity. So that gives us the categories of white, Black or African American, Asian, American Indian or Alaskan Native, and other. And so the Data Collaborative for Justice has gotten privately available data from the Department of Correction before that does include reporting on ethnicity. And so we know that this other category is largely representative of people of Hispanic or Latin origin. However, it is important to note that the person who is collecting this data, so a DOC staff member, is reporting on the race of the person incarcerated or being admitted into custody. And so they could also categorize someone of Hispanic or Latin origin as Black or as white. So just keep that in mind as we move forward. We'll also report on gender as men and women and mental health designation. And so in the data, this is flagged as something called Brad H status and is a binary flag of yes or no. And it signifies if someone has received a mental health treatment while in custody. So the first thing that you'll see when you go into this tab is summary statistics. What happened in the last 30 days? And so overwhelmingly so, the majority of people in jail are non-white, they're men, and they are people who have received mental health services. So for the sake of this talk, I'm going to actually jump straight into the mental health services section. And again, this is talked to as Brad H status. What does that mean? This signifies that someone has received mental health services while in custody. And the term Brad H actually originates from a lawsuit filed against the city in the late 1990s and obligates the city to provide discharge planning for people who were flagged with a mental health service while in custody. And these discharge planning services would include things like continued mental health services, case management, and public assistance in housing. So the first thing that you'll see in this tab is just a historical trends. The percent of the overall population that were receiving mental health services while in custody. You can see that there is a very clear upward trend here, and there's a weird little anomalous hump during the COVID-19 pandemic. So currently, more than 1 in 2 people, specifically about 56 to 57%, have received mental health services while in custody. And again, we have seen this change persist over time. Specifically since 2016, the percent of people receiving mental health services has increased by about 32%. And over the last year alone, about 1.5%. This increase could be due to many factors, whether it's increased policing and incarceration of people with mental health needs, or increased mental health counseling and resources while in custody. It's hard to say, but based on these trends, we do know that a growing portion of people being incarcerated and discharged need resources and access to reliable healthcare. And we should be investing in our underutilized mental health courts. I'll quickly also just review the racial disparities and the gender disparities so you guys know what's in this tool. So like I said, the overwhelming majority of people currently in custody are non-white, 92% specifically. And that includes 59% of the incarcerated people being Black, 31% of the people incarcerated as other, which is most likely to be Hispanic, and only 8% of the people in custody currently in the last 30 days are white. Historically speaking, this narrative has not changed. Some might look at this graphic and not find it compelling. I would beg to differ. I think this paints a clear picture that the vast majority of people in custody, historically speaking, have been Black and brown. And that would be, sorry, the blue and the red area here. We also wanted to make sure that we included census data. So this is the general population of New York City, so we could understand if the population currently incarcerated or historically incarcerated is representative of the overall population in the city. That is not the case. So we have found that Black and non-white people are incarcerated at much higher rates compared to white people. So in the last 30 days in this table to the right, you can see there were 3,856 Black people incarcerated on Rikers Island on any given day in the last 30-day period. That's compared to about 1.8 million Black residents in New York City. That then gives us an incarceration rate, which is a per 10,000 resident metric of about 21. So there are 21 Black people incarcerated per 10,000 Black residents in New York City. When we compare that to white people, in the last 30 days, we've only seen 515 white people incarcerated on any day in the last 30 days, excuse me. And that leads us to about 2 white people incarcerated for every 10,000 white resident in the city. And you can also see these metrics represented here in this graph with colored little people. So to quantify racial disparities, we use this thing called a rate ratio, where we compare one group's incarceration rate over the other. If our criminal legal system was equitable, we would assume the racial disparity would be equal to 1, right? So the incarceration rate of group 1 over the incarceration rate of group 2, the fraction would equal 1. That is not the case. The largest disparities actually in the population exist among Black and Asian people in New York City. Specifically, Black people are being incarcerated at 17 times higher rates than Asian people. And then the second largest disparity is happening among Black and white residents in New York City. Specifically, Black people are being incarcerated at 11.5 times higher rates than white people. Now we aim to do exactly the same thing, but for gender. And so this graph actually allows users to choose which class of information they're interested in. So that would be men or women, and what type of metric you want to report on, whether that's a total number or the percent of the total population. So it's kind of a user's choice, whatever you like to see. However, one thing that I really do want to point out here are these descriptive text to the right. We tried our best to kind of paint a picture for the user and to not only just give them graphs and numbers, but to also kind of lead them through the experience. And so I want to bring your attention to the second bullet point, which is the change over time. So the number of men and the number of women in New York City jails over the past 8 years actually have changed relatively the same. So the number of men in New York City jails has actually decreased by roughly 32 percentage points, percent change since 2016. And women have decreased by also 32%. That's great. Except in the last year, there's a very different story happening here. In the last year, men have only increased by just shy of 10%, but women almost 24%. So I hope that this tool can be used to investigate your interest in mental health services for people who are in custody, as well as all of the other things that are happening. There is a section of this dashboard that I will not go over that actually projects the jail population 1 year into the future. Again, to help us kind of understand if we continue with the status quo, where are we going to be at? And unfortunately, the numbers suggest that we will most likely continue to see increases in the jail population over time. And if I were to guess, I think that we would see increases in all subgroups of the population over time. So quickly, key takeaways. I know I went over a lot of stuff and data is not for everyone. So we have consistently seen increases in the population of people in custody on Rikers Island. Those people are predominantly serving for pre-trial detention. So they are just awaiting their trial, not found guilty of a crime. They are people of color. They are men, and they are people with mental health needs. We are closing Rikers because it is inhumane and the conditions are unconstitutional and dangerous, both for the people currently in custody, but it also follows them when they re-enter society and try to reintegrate into society. We need to continue to invest in the services for people who are currently in custody, but also after the fact. Again, thank you guys for allowing me to speak. If you want to check this out on your own time, you can do so at the Data Collaborative for Justice.org under the analytical tools, or at this lengthy URL, which is nyc-jail-population-tracker.datacollaborativeforjustice.org. Thank you.
So we are so rarely in this situation. We are actually running early right now. I try to put in some cushion on the front end because usually I get long-winded. But our first three really stayed on time. So we're going to say we're going to do a 5-minute break, and then we're going to get started at 10:20 on our next panel. Thank you.
the audience, and I'm going to also ask that the panelists for the first panel discussion begin to make their way up to the stage. Okay, so I'm Mr. Rodriguez, Policy Director at the Data Collaborative for Justice, and I am so proud and excited to be partnering with From Punishment to Public Health and Jeff Coots and Tiffany and all the folks who've done an amazing job to bring this conference together. Also, hearing some feedback. I don't know if you all are getting it. I'm also grateful for the panelists who are joining for the first panel discussion. So we are going to have the first of three today. This panel in particular is focused on courts in New York City and how there are healthcare access opportunities within the courts and what they can do, challenges, gaps, the services, the needs that they're meeting, the services they are providing. And again, I'm very grateful to all of you. So I'm going to come over and join them. You okay? Okay. We provided booklets for you all. So every person who's participating in today's program, we have a full length file for you all to review, but I'm going to quickly introduce the folks who are joining me at the table. One moment. Okay, so I'm going to start my far end. Joining us is Kendall Sullivan. She's the Director of Arraignment Court Operations at the Center for Alternative Sentencing and Employment Services, otherwise known as CASES. We're also joined by Zakiya Rose, who's Project Manager for the Criminal Justice Division at the New York State Office of Addiction Services and Supports, also known as OASAS. And Toni Mardirossian, who is the Chief of Pathways to Public Safety at the New York County District Attorney's Office, we sometimes refer to as Danny. And then finally, Aisha Greene, to my immediate left, Bureau Chief of the Rehabilitation Programs and Restorative Services at the Queens County District Attorney's Office. Thank you all so much for joining. So we have this esteemed panel with a wealth of knowledge and experience, and I want to start by giving each of them an opportunity to talk about their work. So I'm going to pose sort of an open question to each of you, and maybe we'll move left to right. I'm sorry, I guess, from Aisha to Kendall, and give you an opportunity to give us an overview of what you do. So can you each offer a general overview of the programs you oversee within the courts, and then how does it intersect with the public health domain?
So good morning, everyone. I really want to thank everyone for the opportunity to be here. Is that better? Yeah. Okay. I want to make sure I'm not shouting at them. And it's wonderful to see so many familiar faces. So as Crystal said, my name is Aisha Greene, and I'm Chief of the Rehabilitation Programs and Restorative Services Bureau at the Queens County District Attorney's Office. And I have the privilege to serve my home county, and I serve in a way where the Prime Victims Advocates Program and the Diversion and Alternative Sentencing Program are both a part of my bureau. So taken in turn, the Prime Victims Advocates Program, folks that are coming into the criminal legal system as victims, witnesses, and survivors, we provide services to them, and that might be mental health services, if there are reimbursement services that they're entitled to from the city or the state. We work with them and give them updates on what's happening with their case and making sure that we're connecting them to assistant district attorneys. It's really important to make sure that our community members who have been harmed also know that they have a voice within the process. Also, with the Diversion and Alternative Sentencing unit, the work that I do there, I work with a team of folks And so we are responsible for about 10 specialized court martial counselors. And that's for both felony cases and also misdemeanor cases. And so there are folks also coming into the criminal legal system, and we know that humans are humans. And a lot of times people say that people do not fit into nice neat boxes, and we wouldn't want them to. And so what happens is we have a lot of folks that are coming to us who may have been victims in the system, but are coming to us as arrested persons. And so they are charged with different crimes. We consider all cases and we screen cases to discern whether or not there is a resource need that the person has, and whether or not the district attorney in her discretion is going to make an offer for a person to participate in that type of intervention in lieu of an incarceratory sentence or a sentence where they are under supervision. And so the specialized court parts that we work with are the mental health court parts. There is one for folks that have a substance use disorder. It doesn't have to be co-occurring. We also work with folks that are coming who are veterans and who have served this country. There are people who also have been charged with possession of a weapon. So we do have a gun diversion program, which is a little bit different than our treatment court program, because they're not coming in with a mental health disorder or a substance use disorder. We also work with folks that are coming into the system. It's a human trafficking intervention court that we work with and make sure that people are receiving services as well. So for each felony court part, there is a misdemeanor court part that we look at. And then some folks do not fit within the specialized court parts. And so we're still screening those cases for opportunities. And so there are folks who will be in what we call an all-purpose part, who are also receiving interventions in lieu of incarceration or probationary type sentence. We work with probation as well, because there are times where there is a sentence of probation, but we want to make sure that people are receiving resources. And so we have probation as one of our partners. And in thinking about the community-based organizations that we work with, there are about dozens of organizations, not only in Queens County, but across the city, and some are also upstate. Sometimes we have folks that are facing charges that are not from the New York City area. So there are folks that we have that are receiving services where they're more connected to their family or where they live. And so we're monitoring those cases as well. Also within the Bureau, there's some reentry work that we do. We work with the Department of Corrections and Community Supervision to provide reentry services, or actually through Fortune and Docs, we co-collaborate to provide services to folks that are reentering the community and may need some assistance. And so when we're talking about the community-based organizations that we're working with, we're really talking about a lot of wraparound services for folks. When we're screening our cases and considering cases, there are times where defense attorneys or other community-based organizations will come to us and let us know what the resource needs folks may have. And so a lot of times we see people with backgrounds where there's been a lot of trauma, there's a lot of housing instability, there's financial instability, and things that have happened for folks. And so we definitely treat that information very carefully. It's not used for anything other than to determine whether or not services can be provided for that person. And so that's what I do at the Queens County District Attorney's Office. And I guess I can kick it over to Toni.
Sorry. Good morning. Thank you so much for having me. I am thrilled to be here to discuss really this intersection, because one of the things we chatted about very briefly during the break after seeing that really powerful and alarming data is that so many of the inequities that we see every day in the criminal legal system, they really are a reflection of inequities in other systems that come before someone makes contact with the criminal legal system. Mm-hmm. And while I think it is so important that we shine a light on data like we saw today, I think it's very important, and sometimes I'm not seeing this coupled with the conversation, and it's just so critical. The criminal legal system can only do so much to address the inequities of the systems that come before. And it's certainly the public health system, the inequities in that system and the barriers, and I know we're going to talk about it today. The education system, the housing system. as Aisha said, the folks that we see coming through our courthouse are often, they're very complicated people, and they have been underserved. They have experienced significant trauma, and the legal system is primarily made up of lawyers. We don't have a lot of avenues. Obviously jail is one that traditionally has been over relied on. And so I'm just so thrilled to be here. And I hope that we can expand, the concern about what the data you saw. It's so important to highlight that. But I think we also need to have that larger conversation about what is leading to those inequities that we see. There certainly are inequities in the criminal legal system, policing and whatnot, but so often what we see is a reflection of some really deeper systematic inequities that we see in our city and our society. But in terms of the work that I do at the DA's office, I oversee all programming and diversionary dispositions. I'm going to focus my comments today on our felony work, but I just want to highlight that we have pre-arraignment diversion opportunities, which before someone even has to return to court to see a judge for the first time, we try to divert them. These are primarily on misdemeanor cases, an hour or two of programming, really with a focus on harm reduction, and then they never even have to come to court. We have all sorts of misdemeanor diversionary programming. Again, it tends to be fairly light touch, and by that I mean 1 to 5 sessions perhaps. But our felony practice, we have 4 felony problem-solving courts. In Manhattan, between about a quarter and a third of all indicted felonies in Supreme Court sit in one of the 4 felony problem-solving courts I'm going to talk to you about today. That is a significant increase from where we were just a few years ago. We have a felony drug court. It was created by statute in 2009. It serves primarily folks who are indicted on non-violent felonies, commercial burglaries, grand larcenies, and you need a diagnosis of a substance use disorder in order to avail yourself in that of programming through that court part. If you're successful in New York County, you get your indictment dismissed. For years, we saw many people with co-occurring mental health issues who were eligible for the court part based on charge and having a substance use disorder, but they were also living with a serious mental illness. And the clinicians in that court part felt that they were not equipped and trained to work with people who were also living with serious mental illnesses. And so the DA's office took it upon ourselves to work with our stakeholder partners to fund a special mental health track in that court part so that folks who were otherwise eligible would not be turned away because they had a co-occurring diagnosis. We have a mental health court part, which is funded primarily through health and hospitals, correctional health services. Unfortunately, the court part only has funding for approximately 50 participants. Can you imagine 50 participants in all of New York County? To avail yourself of treatment in that court part, there's no charge limitations. They'll take someone with the violent felonies if the violent felony of the DA's office and the judge consent, but you do need to have a diagnosis of a serious mental illness, which is, for the purposes of that court part, schizophrenia, schizoaffective disorder, PTSD, bipolar disorder, and major depressive disorder. We also have a veterans treatment court, which I'm not going to really spend too much time on. It's a very small docket. But that's actually a good thing. We don't see a lot of vets in New York County indicted on felonies. When we do, and if they're appropriate, we try to divert them through that court part. There were so many people who, for whatever reason, we could not get services through one of those court parts. And so in about 2018, the DA's office, working with our stakeholder partners, including the Office of Court Administration, helped create and funded to the tune of many millions of dollars a felony alternatives to incarceration. That court part is really one of its kind. It is servicing people who are charged with really the most serious crimes that you can imagine: sex crimes, very serious violent felonies, firearm possessions. We have some attempted murder indictments in that court part. And the court part, unlike some of the other court parts that we work through or that we have in New York County, that court part is not limited in any way based on what someone's behavioral health needs are, or what the clinicians tell us are likely contributing factors to their criminal justice involvement. So what does that mean? Certainly, we do have people with serious mental illness in those in felony ATI and substance use disorders, but we also have individuals who have engaged in criminal conduct because they lack stable housing, because they have underlying trauma, fractured familial relationships, negative social peers. We serve people who are in need of a job, and that's really the driving need. So it's a really incredible court part, life-changing for many of our participants. I'll just briefly say, in terms of the intersection with the public health system, we work with ACT teams, IMT, intensive outpatient, detox rehab, long-term residential, supportive housing, really, all of it. And I really look forward to talking about maybe ways that we can work better with those entities, but I'll stop there.
Testing. Okay. Not used to a mic. This is my first panel, and I have to say that so that I feel less nervous. But my name is Zakiya Rose. I'm the project manager for the New York State Office of Addiction Services and Supports, and known as OASAS. I'm going to really try to keep my acronyms to a minimum, but it is a state agency, and if you know, they only speak in acronyms. But OASAS is a very large agency. We serve roughly 680,000 individuals a year and monitor over 1,700 prevention, treatment, and recovery programs throughout the state. So we ensure that treatment programs guarantee quality of care, and also that they're meeting any state and federal regulations, so that people are really getting the best service that they can. On the actual criminal justice division team, I work mainly with the state facilities and the county jails. We also work on trainings, and then we have initiatives to collaborate with the courts, which I'll talk about in a second. But with the jails and the state prisons, our main goal is to ensure that everybody has access to medication for addiction treatment and also supplemental recovery support services. So there is a legal requirement now for state and county facilities to provide medication, but they also have to provide peer services. They have to provide individual counseling, group counseling, as well as transition and reentry support services. So those are really important to our team, and we work on that every single day, in addition to providing various trainings throughout the state. So we recently did a pretty large training for New York City Department of Corrections. They had like a work wellness day. They had like hundreds of their employees. And so we talked to them about medication. We talked to them about how to engage with incarcerated individuals who have substance use disorders. We also do trainings on self-help, right? Where you guys can find help. If you work in the criminal justice system with the sensitive population, how you talk to them, how you can try to motivate them to get treatment. And then definitely something that we're currently working on is reducing stigma, which has been a really, really big problem, probably maybe the biggest problem, because it does tend to slightly interfere with the level of care some people are receiving. We also, our office gets letters from incarcerated individuals. And so we really investigate and advocate for them and ensure that everybody is receiving, the access to care that's entitled to them under the law. So that's what we do in terms of the jails and the prisons, and our trainings, the collaboration with the courts. So this is a fairly new initiative. I think I was added onto this project in June or July. And it is less than a year old, and it's anticipated to continue for at least another year. So it's a long-term project. We are working in collaboration with our OASAS Recovery Bureau. I think they recently changed the name to Recovery and Social Determinants of Health, and also the New York State Unified Court System. And that initiative is really about expanding access to professional peer services in opioid intervention courts. So opioid intervention courts are a member of the drug court family, but they're a fairly new initiative in comparison to treatment courts. They are pre-plea. So this is before someone has pled guilty or not guilty. The court staff will actually go into the jails and they'll survey people, they'll interview people that they determine are high risk. And if they determine that you would be somebody that's appropriate for the program, then they come in and we'll have a biopsychosocial assessment and screening. And that's right after arraignment. So all of this is meant to happen like within the first 24 hours of your arrest. The earlier presentation about, Rikers and really reducing those numbers, I really feel that this is one of those initiatives that can help with that. We're trying to get people out of the jails and we're trying to, divert them from, further harm as much as we can. So that's like our main initiative with the courts. When I first took on this project, I believe there were 29 opioid intervention courts. Right now, I believe there are 36. So they're slightly increasing thanks to the work of the Unified Court System. They're amazing partners. And I think I'll talk about the peers a bit later and how important they are. But that's mainly what we're doing at OASAS. So.
Nice.
Hello, It's on. Okay. So hello, everyone. As mentioned, my name is Kendall Sullivan. I work for Cases. So my team works out of arraignments in Manhattan Criminal Court. So we are around the clock. Arraignment starts at 9 a.m. and sometimes ends at 1:30. So the program I'm going to be speaking about is called the Rapid Response Team. I may use that acronym RT, but I just wanted to break down what that stood for. So this program is a very unique program. So it is a state-funded program that started because of the needs of behavioral health in the criminal justice system after the pandemic. We were seeing, individuals that were from New York or coming to New York with a lot of needs that were not being met or they did not know how to access. So what we did was we applied for the contract and luckily we got it. And so what the staffing is, it's a 2-member team. So it's a psychiatric nurse practitioner and a senior peer specialist. So they can work individually or in conjunction, depending on, how the participant feels the service needs to be provided. So this is not a mandate. A judge cannot mandate an individual to go see a psychiatric nurse practitioner or to speak to the senior peer specialist. The way we connect the participants to the psychiatric nurse or to the senior peer specialist is they are released to supervised release. So Cases does have a contract called the Supervised Release Program, which is an alternative to bail program in Manhattan. So what the workflow of how we usually find or connect who should be connected to our rapid response team is a number of things. Someone who is coming through this criminal justice system arraignments, we may have already worked with and we may have already flagged that we know they're not connected to services based on mental health needs, substance use needs, housing, anything are basic needs that we all are lucky enough to have that not everyone has availability to. So another way is an attorney may come up to us and say, hey, I just spoke to this individual that I'm representing in the back and, they're actively in a mental health crisis. They may be a borderline 730. So 7:30 is when an attorney feels that they are not confident to stand trial or to move forward and to have those important conversations about their criminal court case. Or the attorney feels that maybe a possible mental health 9.43 is needed. So the mental health 9.43, that is when the attorney shares with the judge that they feel the person is a danger to themselves or to others, and they feel the need for them to be evaluated by CPEP, which is the psychiatric emergency room. If that does happen, a sheriff will get the client from arraignment and bring them to the hospital. Sometimes they stay a few moments, sometimes they are admitted. So our hope is to bridge that gap. Not everyone is granted a 9.43. Some people are granted out 730s, but it's more of what's going to happen while their case is pending. Are we just saying, hey, you need all this help. We acknowledge you need all this help, but go to your appointment tomorrow. That's not realistic for everyone. So what we try to do is connect them either with the senior peer specialist or with the psychiatric nurse practitioner. So with some, it's talking about mental health. We've had clients, on the record tell a judge, Kobe Bryant is their father, or that, they own the Macy's organization. And they are not able to understand what's going to happen tomorrow or where they're going to be sleeping or, who even their lawyer is. And there's such a stigma with mental health and behavioral health that it's great to have this team, because sometimes a conversation with the senior peer specialist can be more of a conversation to open up about mental health. It doesn't have a scary title of a psychiatric nurse practitioner or a social worker that, you automatically assume you're going to go to the hospital or you're going to be injected with medication, but more of education around the crisis that is happening. Unfortunately, as well, we have seen an uptake of opioid addiction. So when we're meeting participants who have been in custody, 22 hours or more, they're in severe withdrawal. So the physical aspect is very concerning in a sense where, it hurts to talk because of the nausea, or, they're unable to sit. And we want to bridge that gap. And as everyone has mentioned, these participants don't check a box. They're not just, they need mental health. They just need detox. They just need housing. It's an array of things. And we want to meet the client where they're at and where it's most realistic for the participant as well. So it is a very small portion compared to the over 5,000 individuals we had released to supervised release last fiscal year. So we understand that we can't connect with everyone, but our hope is that we can at least start that and bridge that gap to the participant and the community where we'll be providing these services at supervised release. What happened? Sorry. And yeah, so we just found it essential that participants feel comfortable in a system that is sometimes uncomfortable. We're conducting interviews in the hallway of Manhattan Criminal Court Arraignments. It is a public hallway. It's a very busy hallway. It's a very popular hallway. So we have to get unique in a sense of, someone who has experienced mental health concerns or a crisis while being overstimulated by, hundreds of people passing by. If it's a press day, cameras where they may think, the press is for them. And what's great about this team is they can go outside of the courthouse. We understand that a bench in the courthouse may be triggering for them. So let's walk and get a sandwich. Or, maybe you're interested in possible treatment. Let's, take an Uber and transition to treatment, where we can then have the conversation of what your concerns are about treatment. What will treatment look like? Or, maybe they're ready and interested in mental health services, and the psychiatric nurse practitioner can complete a psychiatric evaluation. And, maybe they're willing to go with us to our Nathaniel clinic, which is our Article 31 mental health clinic, to complete that full assessment. So that's just a snapshot of the rapid response team, and we'll talk more about it.
Thank you for those overviews. I do want to let everyone know in the audience, as well as those who are at home, that we're going to reserve some time at the end for questions from all of you, and we'll get to as many as we possibly can. One way to do that, if you're in the room, you either have a booklet or someone by you has a booklet. There's a QR code in the back, as Jeff noted. I just want to remind you all that you can use that QR code to access a form and just input your questions, and I will receive them. The second way is online. A link has probably already been shared. You can access the same form the very same way. So just reminding folks that if you have a question, feel free to enter it, and we'll try to get to it at the end of this discussion. So many great points have already been made. And we're talking about really a systems issue, right? Like Toni highlighted well, like the criminal court system is just one entity that is responding to individuals within our city who are struggling with chronic medical conditions as well as cognitive behavioral issues. And I want to turn to you, Aisha, because Aisha, I know you have a wealth of experience both in Queens and different boroughs throughout New York City through the length of your career, and also see quite a few of the problem-solving courts in Queens, as you outlined. And I'm wondering, given this experience, what kinds of things, what kinds of alternative, in doing this work in different boroughs, what are some of the things that the courts are doing well? Because we're going to get into some challenges. We have some questions on that too, but I just want to know, what are some things the courts are doing well, and then maybe we can talk about the challenges and limitations to increasing healthcare access through this particular intercept within the courts.
So it's a great question. And during my career, I've had the privilege to work in multiple boroughs. And so I've had an opportunity to work in Brooklyn as the project director of Brooklyn Justice Initiatives, which is part of the Center now for Justice Innovation. I was the chief of alternatives to incarceration in the Bronx, overseeing alternatives to incarceration there, returning home to Queens County, and also just working when I worked at the Center for Justice Innovation, just looking at different courts across the country. And so there are things that we're doing well, but I do want to say at the top of my comments that all of the specialized court parts across New York City are not resourced the same way. And so that is, and I'm sure we'll get into that as a challenge. And I think something that we do well is that we are learning from each other. You do have to have borough-specific responses to the populations that we're seeing, but in as much as the folks that are coming into the criminal legal system, they're from all over New York City. And so there are times where Toni and I are on the phone because we have a person in common. And there are some times that person has cases in Manhattan, Queens, and the Bronx. And so they're in different court parts, or they have different charges, and we're trying to coordinate to figure out what we're going to do. So I'll say that, we're not resourced the same. And I think that there are things that can happen from grant perspectives, from working with our community-based organizations to make sure that we have similar resources so that we can serve the people that are coming to us. Some of the things that we're doing well, and I see that Skip is here, is that a lot of folks are integrating peers into our parts. And so you heard a little bit earlier that when we're thinking about peers coming in for folks that have substance use disorders, we have peers for our veterans court. We should have peers for our mental health courts as well. And so we should see people who have lived experience or who can meet people where they are and also give them insight into what they are going to face in a criminal legal system. When I think about the peers that we have in our veterans court, again, not all boroughs are sourced the same. Some folks have more peers than others. Some have they also have other resources that are available to them that definitely help the people that are coming into our court parts. They can do escorts, they can do different things. And so what also needs to happen for our peers is support for our peers. We want to make sure that the folks that are doing this work are making a living wage, and that they're also able to get the training and the support that they need to continue to do the work that they're doing. I will say that something that I think is working well or working better is earlier screening. And some of what happens is a lot of times, assistant district attorneys are responsible for looking at the cases that they have come in. And the information that is available to us is either coming to us from our complainants, our victims, witnesses, and survivors. Or if the person is a stranger, they may not know, it's coming from our police officers. Because we have access to things like body cam and we have access to our victims, witnesses, and survivors, we can ask them questions to figure out what's happening for the person that we see before them. We also have a good community with our defense attorneys, so information is coming to us. But some of what we need to do, and it's happening, is earlier screening. And also making sure that that screening is connected throughout the system. And so some of the screening that was talked about a little bit earlier that might happen in arraignments, that might not come to a district attorney's office. I may not see that assessment. And if that assessment is shared with me, and now that I have that information, I now have to figure out, I have to get the person potentially reassessed to determine a treatment plan. And so these things take time. Even though we're doing it, I will say, I'm giving you a bit of the pros and the cons. When we're doing these assessments, we have to make sure that our community-based organizations are well-resourced to do them. And so when we have our assessments out, there are sometimes these assessments are taking a month and a half, 2 months. And it's because we're seeing people with such need that it's almost like trying to wait for the stars to align to get everything together to make sure that we're not setting folks up for failure. So I'm going to have to, if I have a person before me that has housing instability, that doesn't have a place to go, that there is an order of protection that's in effect because the family, and again, this is not the family's first foray into trying to get mental health services for their loved one, they might also be at, their resource end, and they're having to rely on a criminal justice system to help them. Right? The person doesn't have a place to go. And now I'm going to ask them to go to myriad appointments in different places, potentially in different boroughs, and also come to court regularly and have an expectation that they're going to succeed in those ways. And so we are screening more cases. We are getting those assessments. We are working, and I do have to give a shout out to EAC Network. We work with them in Queens County. We have a fabulous team for the treatment alternatives for safer communities. We get assessments from them. The assessments are very, very detailed. And we're asking people to share with us very, very detailed information so that we can get the resources that we need. And even in working with all of the community-based organizations that we work with, and that is partnership. That is working with them to get the compliance letters, to make sure it has good information and things like that. And all of the systems kind of working together. And so we have great connections and great relationships with a lot of our community-based organizations to serve folks. But again, it's like trying to get the stars to align. If you're waiting for housing, if there's a wait list for that community-based organization because they have that person has such a high level of care, like their need, I can only go to 1 or 2 organizations in New York City and there's a wait list. So now there's a wait list. I might have a person that might lose their housing, but I can't get them, and so it's all of these things that we're trying to work together. And so I will say the screening, the assessment, I will say we have great collaboration with our partners in the specialized court part. And so each of the specialized court parts have dedicated staff. So the team that I work with, and they're a wonderful team, there are about 15 of us. I have social workers, case acts, and case managers and lawyers that are staffing the parts. So they're reaching out on a daily basis to the community-based organizations to get the information that we need to provide to the court. And we're staffing the court parts where the folks are within the specialized court part. And so there are times, and I will tell you, I staff the part 2 to 3 times a week, because I think it's important for me to be in spaces and understand what's happening for folks, so that I can come here and go to other places and make sure, you know, that the parts that we work with have the funding that we need to carry out the work and do it well. This work needs to be done well. There are dedicated defense attorneys, and from the data that you're seeing with the folks that are coming in with serious mental illness or behavioral health disorders and co-occurring disorders, defense bar also needs to be staffed well. They have social workers and they have teams that can do different things, but we have a dedicated staff there. The other thing I'll say is Justice Hirsch she's retiring at the end of this year, but she was our justice presiding over our felony court part. I will say that now that we have a new justice that's starting, Judge Earl Gargan, she's fantastic. It's an opportunity for us to look at the part that has been in existence for over 20 years to say, what can we, you know, what are we doing? Is there something that we can do better? Are there efficiencies that we're missing that we can, you know, attend to? I think it's also wonderful when we bring our community-based organizations to the table to talk to them about the advances in medical treatment. Let's not make a mistake. We are at the intersection of a criminal legal system and medical treatment. Medical treatment where there have been a lot of advances, and we need to have a good handle on when you're at this intersection, what should it look like? What does the government oversight from a district attorney's office look like when you're servicing someone for medical treatment? And so I look forward to those conversations. When you have those stakeholder conversations, when people are coming in, what we can talk about, you know, how the part is going to run, and also too, if there are other things that our community-based organizations need from us. And so there are times, you know, when they are applying for different grants or what have you, or different opportunities where they will come to us and say, this is something that we need. Would you support us in this? District Attorney Katz recently spoke at the Task Gala and talking about the importance of making sure that, again, these programs are well funded with the kinds of services that we need. And we're talking about deeper end services. And so those are things that are working well. I will say, and I know other people are going to answer, we're going to continue the conversation, but I do also want to point out, and I think Toni started talking about it earlier, is that there are times that we see people coming into the criminal legal system that have very high needs, and the cases that they're coming in with are not, and this is, how do I say this well? They're coming in with very high needs, and we recognize that they have high needs, but the government oversight or what's happening with that particular case is not going to get that person to participate, and nor should it, to participate in those services. And so I will say I get calls on every week from family members to say, I want you to mandate my person to go into treatment on this pettit larceny case. I know they only stole a small thing from the store, but I want you to hold on to them and make them go into a program for several months. And I have to say, from an ethical perspective, that is not something that I am going to do. And so I know we'll talk about other connections that we're looking to make, and, you know, Toni and everybody talked about it, but I'm also looking for the connection between the criminal legal system and the civil system, and the ways in which we can work to continue to support the folks that we are serving.
My next question is for Toni. So could you give us a sense of what are some of the, you know, as specific as you can get, like what are some of the health related issues, both, you know, within the behavioral health concerns, medical conditions that you're seeing coming through the felony ATI part, and any barriers or gaps to connecting those individuals to the needed healthcare?
I already touched on a lot of the healthcare needs that we see, everything from substance use disorders, mental health diagnosis, trauma. You know, many folks who we work with are in very poor physical health, which has an impact on everything else, the underlying trauma. So I'm going to focus on the barriers because I think this is the audience that can actually try to move, to help move the mission forward by trying to alleviate some of them. You know, many of the barriers we see in our problem-solving courts are the same barriers that as New Yorkers we experience if you have tried to access therapy post-COVID particularly. You know that it is extremely hard to find a therapist that takes insurance. The ones that will take your insurance, they have very long wait lists. That's the same for our participants. And what's so troubling when we talk about wait list in the context of our participants is that many of our participants, the ones who unfortunately have engaged in an act of very serious violence that has caused another person trauma, right? So we can't just pretend that it didn't happen. We really need to make sure that when they return to community, they are set up so they are supported so they can be safe in community. While those people are waiting on wait lists, they're often in custody. And so we see wait list for therapy. We see there is a huge gap of services in regards to, there are many residential substance use treatment programs, but not so many that can serve people who also have co-occurring serious mental illnesses. Our clinicians will refer our participants to numerous residential treatment programs if they believe that's the appropriate modality of care. And it's not at all uncommon that the treatment program will respond and say, we're not equipped, to work with this person. They need a higher level of care. I can think of really 2 to 3 strong residential programs that can serve that population. And I can tell you that many of them have wait lists over 8 weeks. Again, right, the population, the pretrial detention population that you're seeing, many of those are people waiting to access beds. We also, one of the things that we struggle with, again, this is true of people who aren't criminally justice involved, turnover at a lot of these programs. And so you're taking someone who has an inherent distrust because they have been let down so often, and you're sending them to a therapist. And then during the course of someone's legal mandate, they may have 3 different therapists, and constantly they have to rebuild that therapeutic relationship. I mean, it's a shame. I think it has a lot to do with how hard the work is and how underpaid the folks are, but it's a real problem, and it makes people lose faith, certainly in all of the systems that they're touching. We need a ton more ACT teams, right? We also need supportive housing, a lot of it. When we consent to someone's release from custody, or perhaps they're transitioning from a higher level of care to a lower level of care, if you ask that person to navigate life and all of these appointments when they are living in the shelter system, it is setting them up for failure. Public safety, to me, it really does start with housing. And so we need a lot more supportive housing. Information sharing between public health systems. We have seen almost every one of the applicants that we have into our problem-solving courts, they have cycled in and out of psychiatric ERs. If it's not psychiatric ERs, they've just cycled in and out of ERs, perhaps because of an overdose, again, because perhaps they're not in the best of health. They've touched, even treatment programs they've touched because perhaps they've been mandated by parole or probation. It is extraordinarily rare that we see someone who hasn't touched many providers, but it definitely feels, and again, many of our participants are not always the best or most reliable historians, and that's understandable because they're living really complicated lives. But the systems that they're touching are terrible at communicating what's going on. And we have had individuals in our program who are really suffering a significant psychiatric issue. They have an entire clinical team in the ATI part supporting them, but still that team feels a psychiatric admission is appropriate. And so they will send the person to a psychiatric ER. And it is shocking I don't, and I know there are a lot of civil rules, but it is shocking how hard it is to get someone admitted who really needs it. And so I can think of instances where clinicians have literally had to go daily to the hospital to advocate for the doctors to keep this person until they can find a higher level of supportive housing to support them. Seems like it shouldn't be that hard, but again, the issues in that system is driving many of the numbers that you saw in the data presentation that came before this. So I'll stop. There are many other barriers, but I'll stop.
Sorry about that.
So I'd like to direct a question over to Zakiya, and I think it's come up both in your discussion of the courts that, you know, particularly the Veterans Court that you oversee. You mentioned, Zakiya, that part of what the the opioid intervention court model includes peers, like having individuals with lived experience in the courtroom, having direct collaboration and connection with the folks who are going through that court system process. Could you speak to how the significance of the peer model and what do you see as some of the benefits of having them play that integral role?
Yeah, yes. So it was mentioned a bit earlier that professional peers are focused on recovery, and they're also focused on meeting people where they're at. Those are two things that are really, really important for the opioid intervention court model. I also call them OICs every day, so stutter as I throw the acronyms out the window, but they're very important because this program is voluntary. There is no legal mandate forcing someone to participate. That would be unethical. And so because of that, it's hard to get people to participate. Opioid use disorder affects your brain in ways that sometimes supersede your own will and what you want for yourself, and what, you know, is going to be the healthiest, best long-term option for yourself. So sometimes you really need a person that has lived experience, someone that you could look at and say, okay, well, he or she knows exactly what I'm dealing with because they have that experience in their past. So they meet them where they're at, but the certified peer is also specialized in helping to get that person connected to treatment and or other recovery services. If you think of your traditional treatment court as like a hospital where they're providing more long-term, you know, support to a person on their journey, you can think of the OIC as like an emergency room, right? So it's very early, it's short-term, and so you need a person there that's going to bridge the gap and get people to participate, right? Increase the program numbers, but also get people connected to the resources in the community. People have a lot of different barriers. We visited a court, and you know, there are children there. People need childcare, right? People need housing. People have co-occurring mental health conditions and need counseling or other types of treatment. So you need someone there to kind of be a warm handoff. And we really encourage that through the use of recovery community outreach centers, which is something that if you'd asked me before I joined OASAS, I would maybe have like a different kind of description, but then you go and you visit these centers and you really see that they're a complete hub for comprehensive services. So if you are a person with substance use disorder and you're working with a peer and the peer is connecting you to exponents or foundations, when you go there, you can get connected to treatment. So our COC, the recovery community outreach centers, are non-clinical, but you can get connected to treatment. You can get connected to clinical treatment there. You also have access to non-clinical services that'll help build your recovery capital and give you a better chance at having a long-term recovery. Does that answer your question?
Yes. So for Kendall, so you described
the program, what you offer within the rapid response program, having a psychiatric nurse practitioner right there at arraignment. And I just want to add a point to something that Kendall said earlier, that arraignments go from 9 a.m. to 1:30 a.m. I just wanted to throw in the a.m. So there's lawyers, there's judges, there are folks working to that early hour. And I just want to cite, like, just imagine the services you might be able to access at, say, 10 o'clock. Someone responding to a trauma, someone having an immediate physical emergency. So I highlight that because it speaks to the importance and the role that a program like this at arraignment is playing. So with that in mind, I want to ask you, could you speak to maybe the immediate impact the program has, like day of, as well as any longer term impact that you may have observed in your role?
Yes, thanks. So I've mentioned that is our biggest hump, is that from 9 to 5, 9 to 3 p.m. we can service a lot of participants right from arraignments, but it's after the 5 o'clock, it's after the 7 p.m. that we have to get really creative with referrals. And so what we did was we were noticing the need, and we really took a snapshot at our data, and our highest needs are Wednesday, Thursday, Friday, and Saturdays. So we actually had a new psychiatric nurse practitioner on board with a unique schedule where she is working a 4-day schedule, but longer hours. So it doesn't mean that after 5 o'clock you were arraigned, oh, well, that service can't be provided. So some of the important role with the nurse practitioner is, building, assessing the behavioral health needs that, I do have some clinical staff and I have some non-clinical staff. So our hope is that they can bridge the gap of the behavioral health needs at whatever hour. So as I mentioned with the 9.43s, just this fiscal year that started in July, individuals placed on supervised release, there were 25 individuals placed that received a mental health law 9.43. Not all of them were hospitalized. So our hope is, bridging that gap as well, is that the psychiatric nurse practitioner is able to meet the participant at CPAP and, similar to what Toni said, is advocating, is sharing the snapshot of what happened in arraignments, because many times we'll get a call and say, like, hey, why was this person sent to the hospital? And I'm a little confused because based on what I saw, I don't know how they're not showing or exhibiting those behaviors in the emergency room. So what the point is really to then have a follow-up. So if it's the psychiatric nurse practitioner or the senior peer, there's a follow-up. So it's not just like, hi, I met you in arraignments. We maybe sat down and built rapport for, 60 minutes, an hour and a half. Now you're just on supervised release, focused on your worker. There's that important follow-up because, as Toni mentioned, is, if you're willing to and you're open to and you're finally, trustworthy with someone to then be passed off to another person can really, disrupt that therapeutic alliance. So it's important that the psychiatric nurse practitioner and the RRT team connects also with the supervised release team in the communities so that the case coordinator or the social worker in the community knows what was worked on straight from arraignments. So we're not meeting you again and saying, hey, what do you need? Or starting all over with questions that have been answered, with traumas that have already been discussed and disclosed, but it's a continuum of care. And that's what's great to see. And as well as us having therapists at our supervised release, 2 of our 4 sites, is that we can also then continue that care of, speaking with the therapist, as well as providing those ongoing referrals. And our hope is to then assist, which we have seen in our data, of the reduction of at least felony arrests.
I see that we're quickly approaching some of our Q&A time, and I appreciate the folks who have entered questions into the Google form. I want to ask another question that, I feel like each of you may be, from a unique perspective, able to respond to. We are talking about this enmeshing of public health systems, health priorities, and health approaches, clinical approaches, and the criminal legal system, and oftentimes circumstances where a legal mandate is involved. And that means there's judicial oversight, there is accountability to the court, there's questioning of how that person is progressing through the treatment plan. And so I think it's a hard question to grapple with, but I just want to spend a moment thinking about it. We could probably have a whole conference on that. But that tension that might exist between clinical versus legal goals. And so, Toni, maybe I'll start with you. So living in that intersection, right? How, those clinical goals do not always align with the demands of the court. So could you share more about that? And maybe to you and to others on the panels, on those of the panel, if you have thoughts that are germinating as we talk about this, what are some ways that we may overcome some of those challenges and some of those limitations of seeking as the individual engaging the treatment and increasing access as like the folks in the room that are privy to making these decisions? How do we make sure or try to overcome some of that tension?
Okay, so clinicians, it's, typically if someone goes to see a clinician, even if they have minimal insight or motivation, they still have enough that they got to the appointment, right? This is outside of the context that I work, that we all work. When you are in the court system and you're under a legal mandate, you don't always have the motivation or insight that someone who goes to see a clinician voluntarily has. You are choosing to avail yourself of treatment, usually because there's this heavy extrinsic motivation. You have a court case and you're trying to avoid whatever consequences will come with it, which often, again, in the felonies that I'm working on, it's usually jail or prison time. And so, clinicians are very patient-centered, which is great. That's what they should be. What are your goals as an individual? You don't want to stop using opiates. Okay, let's talk about how we can keep you safe when you're using them. Perhaps we can talk about reducing your use. As a court system, we certainly are focused on the individual. And I'll tell you, in my next life, and this is not to minimize how important and hard the job is of a clinician, but I am often envious that most clinicians can focus on one person versus, I'll speak as a prosecutor, we have to focus on that person, the community, a survivor who has come, and overwhelmingly in Manhattan, and I'm assuming probably the same in Queens, what most victims of violent crime will say to us when we talk about the potential of an alternative to incarceration is, I support it. I saw myself that the person needs help, but I want your assurance they're never going to hurt someone again. And we can't give that assurance. There are many people who we refer to programming and they do not engage. And so we have to look at a much bigger picture. And I think that while it's amazing that clinicians can be and should be patient-centered, the court system is a little bit different. We're not just asking, what do you want as an individual? We are really asking our treatment court clinicians who create the treatment plans, what do they need? What do they need to be safe in community? And sometimes that means that this individual really needs to take mental health medication. They really need to engage in substance use treatment because those needs drove them to commit a really serious crime. We can't always accept that someone, maybe a clinician can accept that someone's not ready for medication. I get it. But often our contracts will say, if recommended by a doctor that you take medication, you have to take it. And so it's this really, I would say, challenging dance that we do. But I think the way the clinicians and courts can work together, first of all, this idea of being person-centered, the understanding that clinicians certainly have that recovery is not linear, right? It's a process. And I think that our courts, at least in New York City, have gotten a lot better in recent years about understanding that. It's not like flipping a light switch and suddenly substance use is going to stop and, mental health systems will evaporate. It's not that, right? It ebbs, it flows. And so generally speaking, one of the things that we hope in our partnership with community-based treatment programs is that they will be in close communication with us, because treatment court mandate can be a very significant motivator. And if someone is not making their outpatient treatment appointments, if we know that quickly, we have a lot of tools at our disposal, right? We can have the individual come to court, not with the goal of remanding them per sentence, but the judge can remind them, don't forget, you signed this agreement. We need you to do that. Or perhaps you need a higher level of care, and we can have that conversation as a treatment team with the community-based providers. There's tons of intersection, right? MAT, years ago, to graduate our drug court, if you can believe it, you have to get off of methadone. Now, look, it's obviously the decision between patient and doctor, but personally, I think methadone helps people stabilize in the long term. And again, it's not my role to encourage it, but when someone says that they really want to taper off, I keep it to myself, but sometimes I get a little concerned. The court will remind people you can stay on it, don't feel like you have to get off. I think that again, it's a very hard intersection, and I have so much respect for community-based providers who do the hard work. I think there's a lot of intersection. I think that one thing I just want to mention that didn't maybe come up before is that, and this is controversial, but it's something I think we need to acknowledge. A clinician said to me one time, these were her words, but they resonated with me. She said, you have to be sick enough to need an ATI, but well enough to engage in one. And we see people every day who don't have insight. They are refusing to take the mental health medication that really they need to make the clinical advances in therapy. We know that most people living with serious mental illness are much more likely to be victimized than they are to be perpetrators of crime. The narrow population that we work with are the few that they have perpetrated a very serious crime. And so if they are telling our teams that they're not going to take medication, they're not ready to go to treatment, they're not ready to address the underlying behavioral health needs that drove them into the criminal justice system, we have very few options. The option we have is the data you saw before. It is jail. And so there is, I think, an eagerness on the part of many citizens and prosecutors for what sometimes is called like a third lane. I think that treatment people receive in prisons, there's an array, but it would be really wonderful if there was a therapeutic option, but that folks maybe just couldn't immediately walk out of. Because like I said, we refer people to the highest level of community-based care there is, and we do see them leaving. And it's a real challenge. And so really I'm looking to the public health partners to try to address that gap.
Yeah, I'm going to pass it to Aisha and then Zakiya and Kendall, if you want to chime in on this question about like this intersection and tension. I did want to note that we have a community-based panel at the end of the day, which I personally am very excited about. And I think speaks to the needs that they're all raising, highlights the fact that a lot of the resources that we're seeing when someone has entered into the criminal legal system and has a case that's being adjudicated, those same needs are present. Well beyond that touch point, right? We just happen to be focusing on that in this panel, maybe could work to prevent some of the criminal justice involvement. I just wanted to, yes, and Aisha, please.
So I do want to make sure that we leave time for questions. I do want to also say, to Toni's point, there are a lot of folks that we see that our judges are meeting them where they are. And so there are some folks that are just like, I don't want to take medication now, or what have you. And again, because we're at this intersection, a judge may say, okay, we're going to see how this goes. We're going to see how this goes for a little bit. And we're going to continue to check in with you. I do want to let you all know too, that when we say yes, and these are very serious cases, I know Toni mentioned We both have cases that are attempted murder, assault ones, we have arson cases, we have very serious cases that folks may get rearrested. And we know that that may happen, and they may get rearrested on really serious charges. And I will say that there are times when that does happen, and we're looking at the case and we will evaluate it to say, I still think that this person needs this mental health treatment, and we will continue to move forward. I know that I don't know everyone who is in the audience, but I do want to say these core parts are open for folks to come and experience them for yourself. We do ask that when people are coming that they are very respectful of what's happening in the court part, because a lot of very sensitive information is shared. But come and see, and I think that you'll see exactly what we're talking about happening right before your eyes. And so I do want to extend that invitation to all those that are here.
Oh, sorry. Just very quickly on, I guess, how OASAS tends to mitigate the tension. More recently, we've really focused on hosting a lot of collaborative meetings and webinars that are reoccurring, and then across the spectrum. So we have them for providers, we have them for jail-specific providers. The Recovery Bureau is working on having them for the peers that have already been placed into opioid intervention courts. I think there are about 16 different courts that already have peers, just so that we can increase and improve communication. Because when people are talking to each other, different providers are talking to each other, they can mitigate some of those tensions. They can discuss any challenges or barriers that they or either incarcerated individuals or court-involved individuals are facing, and collaborate and come up with other best practices and just stay up to date. So that's one of the things OASAS is doing.
And then I'll be quick as well. I think the biggest is communication and transparency. So what's big with cases is we've luckily been in Manhattan for a while, so we've built those relationships with judges. So when someone does, if there is a small success story that someone did make it to treatment, we're going to share that. But we're also going to share that, unfortunately, that person did get out of the Uber and is not ready. But still educating the judges that it's a journey and that it's not because this one participant wasn't ready that we should now make another decision for the next person to not be given that opportunity. So I think that just continued conversations with different stakeholders in the courthouses really helps with deciding what is the best fit and making different hard decisions.
I do appreciate you all taking on that hard question, not just on this panel, but probably every day, right? In your experience and work. I do want to turn to some audience questions, and we have some great ones, but I'm going to do my best. Okay. So one question is about net widening. How do you prevent it, I guess? I want to say something for folks, this is an issue that comes up every time you're implementing something within the criminal justice system. How do we know that that particular program or intervention is meeting the folks who absolutely need it, as opposed to taking in folks who may be lower risk, as we discussed it, or lower needs, so that we're not over programming? But I think implicit in this question is also the fact about resources, right? There's number amounts that tied into these programs, into the staffing. So how do you make sure the resources that exist are sort of reaching the folks who can yield the most benefit, who can best serve? So whoever is ready to go for it.
So I'll just say, and I know Toni pointed to the number of folks in the Manhattan mental health court is 50. We have a population that's also not large in Queens County. I can tell you we're seeing a lot more people that have the need and we're not able to serve than the other way around. New York City is a very resource-rich place. And so that's great and it's wonderful, but I know we're seeing more people with very high needs and very serious charges. And so when you talk about net winding in our non-specialized court parts, there are times that people, we believe that they'll need services or interventions. And again, it's up to the person if they want to avail themselves of it, and so they can say no. And so the other thing is sometimes there are multiple options. I don't want folks to think that it's either just jail or prison or this program that we think you need, you don't think you need, and you don't want to take, that there are other options for folks. So there are times that people are taking dispositions that don't include any programming at all. And I don't know, Toni, if you agree with me, but I mean, I don't want to have people come into the criminal legal system that need these kinds of services, and that's what's bringing them in. And so I'll say that we have, I think that we could take more serious cases, but we don't have the resources or bandwidth to do it.
I totally agree. I also think, and this gets complicated, and it's a side topic we don't need to get into, but post 2020, when the discovery reforms were passed, I think it really recalibrated the sorts of cases that are being pursued in our criminal legal system. Again, it's totally side topic, but I guess I would say in my experience, if you are getting indicted, on a felony nowadays, it's usually because you are either because of the crime that was committed or your criminal history, you really are that kind of high risk. We certainly are educated about risk need responsivity. When we talk about these problem solving courts, we really try to educate our lawyers about, we want, for this dramatic intervention in the felony space, we really want people who are at very high risk of reoffense. Those are the people who need this intervention. And we have those conversations where if someone appears low risk, the best thing you can do is try to divert them out of the system and not kind of keep them attached for one of these mandates. But in my experience, I agree with Aisha, there's usually more folks who really need it, but we can't service them.
Sorry.
And our assessments, the last thing, our assessments will tell us when we're talking about R&R, they'll tell us about the risk and need. So
I want to turn to another audience question. Kind of long, but I'm gonna get to what I think is the purpose. We just went through that review of the jail population. So clearly there remains individuals who are incarcerated, who in pretty terrible conditions, right? That's why we are in the circumstance we're in New York City under a federal monitor, potentially a federal receivership. And we know there's a significant and a growing, over recent years, number of individuals who are at least flagging for mental health needs, right? Referring to that Brad H flag that Liz touched on earlier. And we also know, or the CHS also releases data on the kinds of diagnosis of mental health that are appearing within the jail population, as well as things like alcohol use and chronic medical conditions. So there remains a need, is what this questioner is posing, and what kind of capacity exists and is still needed, and where do program gaps remain that maybe prevent more individuals from being released from the jail population? I hope I did the question justice. Yeah.
I maybe I'll hop on this one, just because we communicate with the jails and prisons a lot. So even as recently as this week, one of the things we're working on is getting more providers to have a presence on Rikers so that the individuals there have better access to referrals. Again, more of a warm handoff to referrals once they're discharged. So I think one of the main things is, one, making sure that everybody has access to what is their legal right. So things like medication or assistance with their mental health, but also continuing to work on improving what's available to the people that are incarcerated, because they are a captive audience. They don't have the option of, going to exponents and then maybe going to foundations, or not so we want to just try to make sure that they're provided with services while they're incarcerated that will help their transition once they release. And not just releasing people with a comprehensive discharge plan. That's very specific to what we're specifically working on with Rikers, but it's also a requirement for all of the county jails. So we're constantly in communication with the staff and the jail administrators to make sure that they are following those regulations. And when we do receive any complaint or any notice from incarcerated individuals themselves, because we do get letters and things like that, we make sure to investigate it thoroughly so that everybody is being treated fairly.
I think I'll highlight two things. And I think the question is for people who are receiving care in community.
For people who are currently incarcerated, like what are the gaps in services and capacity needed in order to facilitate care?
So I'll say, and I think we talked about this earlier, folks that are incarcerated that also have like high medical needs. And so there are folks that might need dialysis or might need some other things, or they have chronic issues that if they need to go into residential care, that residential care facility cannot accommodate it. While this might not just be for folks that are incarcerated, I would say that it also happens for others. We live in a very diverse city, and so we need more services that can accommodate folks who speak another language but need residential services. And so there have been times where I have folks who are incarcerated also in the community, and their preferred language is Mandarin, or they cannot participate in a program in English, but I don't have a residential place that can take them that can accommodate their language need. And so now I don't have anything.
Also, just quickly, people without legal status, we are seeing a real issue, particularly if the clinician suggests the person needs a residential treatment setting. There are very few, they call them scholarship beds, that will accept them. And again, some of those people are sitting on Rikers waiting for a scholarship bed to become available. If one does become available, and look, again, it's a process. Sometimes people leave. We want to replace them. To try to get another program to give that person a scholarship bed is a huge issue. Never mind when they come back to community and they need to access medication and mental health treatment. These are very hard things to do if you are not Medicaid. They're hard enough if you are Medicaid eligible, and if you are not, if you do not have benefits, it's almost impossible.
We only have like 2 minutes. I want to give Kendall a chance to, I don't know if you want to respond. Sorry, I know we're like really close on time. If you want to get a discussion about like gaps in services or capacity or resources needed in community.
Yeah, I think the biggest is communication as well, and staying in touch with those different community providers, vice versa. Because I think with more conversations, you learn more that, something may have happened yesterday that now there's a new eligibility. So I think what's really big is making sure that we're staying in contact with our community providers, that, it's not always, what we've learned is like, it's not always their job to reach out to us. Sometimes it's staying in that contact. So then when something does pop up, they think of that person, they think of the organization that's constantly reaching out to them, checking in on how those programs are going. And then, because I think that's a biggest gap, is a participant may actually enroll in a program, and then, we may find out that they left, but we found out a week later, and now we're trying to re-engage them in those services, but we don't know where to look for them. Or where to reassess because of that abrupt leaving of the program. So my hope is just there's a lot more conversations. There's a lot more, the pandemic brought Zoom calls. So just all these conversations where we're able to talk about the great work everyone's doing in the community and come together to see how we can each benefit one another.
Thank you. Thank you. We're just about time. I'm really grateful to all of you for taking the time to prep for this conversation and joining us today, taking the time out of your busy schedules to help inform and educate all of us. And I want to announce that we are moving into a break, a coffee break, a short coffee break. So for those of you online and for those of you in the room, we're going to reconvene with panel 2 at 12 o'clock, about 14 minutes now, in 14 minutes. Okay. Thank you. Yeah, I've been sitting on the I think we can start with the Mardirossian.
Yes.
Yeah, apparently.
Hi, everyone. So we're going to kick off panel 2 on jails and prisons. My name is Tiffany Sloan. I'm the project manager at From Punishment to Public Health. I'm also an alum of John Jay College. Please bear with me because this is my first ever time moderating. So, but I'm excited to be here. We have a great panel for you guys. We will dive into complex and often overlooked intersections of healthcare and the criminal justice system, and we'll focus on the unique health burdens faced by individuals in carceral settings and the persistent barriers to accessing adequate care. We'll also be touching on recent innovations in serving individuals with substance use disorders and serious mental illness within jails and prisons, and strategies for improving care transitions and ensuring better support for community reentry. So I'm going to introduce the panel, and they then will go and introduce their program. Some of them do have slides as well. So first, we have Sumeet Sharma from the Correctional Association of New York. He's the director there. We have Matteo from Keep Reentry. He is the coordinator there for the Correctional Health Services and New York City Health and Hospitals. And we have Mervin Otero, the program manager at Osborne. And we have Trevor Cummings, the senior program manager at New York City Health Justice Network. So to start off, Sumeet, if you want to start off and introduce your program.
Sure. Folks, hear me? All right. Is that better? Yeah. Great. So good afternoon at this point. My name is Sumeet Sharma. I'm with the Correctional Association of New York. The Correctional Association of New York is a fairly unique organization in the sense that it was created or established in 1844 by the state legislature to provide independent oversight of the state prisons in New York. What that entails of is essentially we're a group of civilians who don't have an appointing authority right from the governor or from the legislature, but are designated by state law. It's Correction Law 146, if folks are curious, to visit and examine the state prisons. So what that entails of is physically going to the 42 state prisons in New York, conducting multi-day visits by which we're able to speak with staff and incarcerated individuals confidentially. And then a second piece is issuing reports to the legislature, the executive, and the public by large. We also are able to operate a hotline for the reporting of concerns directly to us from state prisons, and also issue surveys on a number of topics. Right. So I just want to, I guess, provide a brief overview of the different ways that the Correctional Association of New York is able to access information, right, that might not be coming out of a state prison. These state prisons are very, very far away, and the role it plays in disseminating that information to the public. Right, this idea around civilian oversight is unique. Again, there's two other similar organizations in the country, in Pennsylvania and Illinois, that conduct independent oversight of prisons and jails. But it is centered around this concept that, right, prisons and jails are a part of our public community, and there should be a level of, right, oversight by the public and by civilians for the system. So excited to dive into this conversation today, and thank you so much.
And next, Michael.
All right. Hi, good afternoon, everyone. I am Mike Matteo. I'm from Correctional Health Services KEEP program, and I will explain what that is in just a moment. Please bear with me. I do have slides, as mentioned. This began life as a 40-minute presentation. It's been heavily abridged to be maybe about 10 minutes. And I'm going to do my absolute best to make this kind of a quick and dirty introduction and overview of who we are, what we do. Thank you. And kind of just get the conversation going around some of the barriers that we face, specifically as it relates to reentry for patients enrolled in our program, and also some of the opportunities that we've been exploring. So very briefly, KEEP is essentially the OTP, the opioid treatment program for the New York City jail system. We've been around since, I believe, 1987. KEEP technically stands for Key Extended Entry Program. I'm pretty sure that's one of those things where the acronym existed first and then they had to plug words in later on. But back in the 80s, it was the program that kept people on methadone treatment if they came into the New York City jail system while they were receiving it in the community. Whereas other systems, carceral settings, were not doing that at that time. We offer all federally approved medications to treat opioid use disorder, which are methadone, buprenorphine, which is typically prescribed in the community as Suboxone, but there are other formulations. We offer an injection for that as well as naltrexone, which is also usually known as Vivitrol in its injection form. We do offer medication for alcohol use disorder. We do offer some pretty limited services in terms of harm reduction for people that don't have an opioid use disorder, alcohol use disorder. So wouldn't be eligible for medications, but may still come on our radar and need some support. So as of last month, KEEP was providing medications for opioid use disorder to over 800 patients. So we're talking about 13% of the entire New York City jail population. So this is a pretty significant number of people who are incarcerated on Rikers on any given day that are receiving these medications. It's like the pie graph may have gotten a little messed up, but about 30% of our patients currently choose to receive buprenorphine or Suboxone as their preferred medication. About 70% choose methadone. The reason that's highlighted, these medications look pretty different in terms of aftercare planning and discharge planning and how they're managed in the community versus how they're managed inside the jail system. In the jails, it's, I don't want to say easy access, but fairly straightforward regardless of what the medication is. You leave your housing area, see a nurse, receive a dose, versus in the community, buprenorphine tends to be prescribed in office-based settings through doctor's offices. You may only have to go once or twice a month to see a provider to receive that prescription. With methadone, you're typically going to an opioid treatment program several times a week. There are pros and cons to each approach. Some patients find one approach better than the other, but our job as clinicians is to ensure that patients are educated when they choose what medication they receive in terms of how that will impact their discharge planning. Discharge planning barriers that are really just inherent to the jail system. Unlike the New York State prison system, where people have known release dates, the overwhelming majority of patients and people who are incarcerated on Rikers are detained. They have no known date of release. They may be released unexpectedly when they post bail, when a case is dismissed, when a warrant is lifted, when there's a court ruling. And these releases can happen just about any time. They can happen at 12 in the afternoon, 12 at night. They can happen right before the weekend, all these times and places where our clinicians and our staff are not available, or community resources may not be available for them. I think it's just important to highlight that due to the nature of what Correctional Health Services is, which is a healthcare system that's operating inside of the jails, we're also in this very unique position where we don't have direct input or control of when people are being discharged from the care that they're receiving. Because of all of this, the main point I want to highlight here is that our discharge planning is not done when people are released for the most part. It's happening at the point of admission into our program. That's a huge barrier in and of itself. The reason that we do that is because that is the one guaranteed time we have to be with a patient, interface with them, provide the amount of information that we can in terms of making a referral and getting connected to community services. But I think, as most of us are aware, when you're first coming into the jails, if you use opioids in the community and you're starting medication, you're probably at a point where you're in active withdrawal, only receiving a low dose on a detox. You're getting a lot of paperwork thrown at you, a lot of information, a lot of things to sign, and all the while you're really just trying to feel better and not necessarily paying attention to all of the stuff that's going on or all this information that's being presented. So we do our discharge planning this way because it's kind of the way the system is apparently set up, but in and of itself, it is a bit of a barrier. Additional barriers that we face as an opioid treatment program when it comes to doing discharge planning for our patients. As many of these releases to the community are unplanned, we're usually not aware of those or able to track them until after it's already happened. I've had plenty of times when patients have connected to a program or gone to fill a prescription or called me and I had no idea they were released. It just happened, late the night before. As mentioned, people may lose the information that we provide, an aftercare letter that they would bring to their program. They often have conflicting responsibilities and appointments. Many people leave. They may have an outpatient program to attend. They may have to navigate HRA to sort out their benefits. They may have to see a parole officer, and all of that can conflict with that very urgent need to connect to methadone treatment or to fill a Suboxone prescription in the community. People often are usually released without photo ID. That's definitely a barrier if you're showing up to a program that's trying to confirm who you are and what your identity is before they dispense medication. And as mentioned, patients are often discharged at really unpredictable and not great times and hours in terms of connecting to care. Some of the ways that we've been working to offset some of these problems and improve our own discharge planning and what patients have available to them. We are doing more specific and targeted follow-up visits with patients. So we do try to target people who are brand new to the treatment landscape, who have maybe not received methadone or buprenorphine or another medication like this in the community before, so don't have the best sense of what that looks like and what aftercare looks like and all the steps that it would entail. And we are doing regularly scheduled follow-ups with our patients a couple of weeks after that initial encounter, first with the nurse, and then about a month after that with one of our clinicians. Again, we really try to tailor our education around these medications for people that may need that information. We have been talking about bringing peers into our service. I know that's been brought up a couple of times, that real importance of having peer support and a peer that can help somebody navigate some of these issues. And I think just generally better collaboration with everyone, every stakeholder that's involved. And that's with DOC, that's with social workers, legal services in the community, attorneys, and I'll go into that a little bit later on. There have been a couple of other workflows that we have talked about or in some sense tried implementing to address some of these reentry and discharge planning barriers that are specific for people who receive medications for opioid use disorder. One is that in some cases we can coordinate guest medication with the community program if we know in advance that somebody is going to be released on a Friday at a time that they normally wouldn't be able to connect with the program over the weekend. The problems with this are, again, it's a very small number of patients that we have that have these no releases. It's about 8% of the entire Rikers population as of earlier this month. So this is only a targeted group of people that we can really try to do this coordination with. Also, across New York City, not all opioid treatment programs have that capacity to provide medication for patients on a weekend. And just for broader context with this, so for patients who receive methadone specifically, the current system, the only way to receive that medication is to connect to an opioid treatment program in the community. Those programs are staffed by medical doctors, other medical providers, social workers, counselors. They are able to receive our patients on short notice during the week if they arrive between Monday and Friday, but most programs don't have doctors on site or the administrative staff on site on weekends to be able to take folks that get discharged on Friday and need these services. So even in the best case scenario where we are able to coordinate medication for somebody that we know in advance being released before the weekend, because limited availability exists in the community, they still may need to travel to another borough or do something that's a bit inconvenient. There have been talks about what walking medication would look like coming from the New York City jail system. The two main barriers with this are that many of our patients get released from court unexpectedly versus being released from Rikers. They're not able to leave with a walking supply of control medication from the courts. And the reality of the jail setting is that when persons who are in custody are being released, they're usually housed in these holding areas with other individuals. And there's a significant risk of the medication being distributed, which leads to the inevitable risk of overdose if that medication goes to somebody that has not been taking it. Some of the opportunities, some of the things that we have discussed with some of our own community partners in terms of how do we address our barriers on the community side. For people who receive these medications and are released from Rikers on the weekend, the typical option is to go to an emergency department. A lot of barriers with emergency departments. Anybody who's been to an ER for a non-acute emergency knows you may be waiting there for many hours. And most follow policies where they're not able to actually verify the medication dose the patient received on Rikers. So we may have somebody that was released on 200 milligrams of methadone, and that emergency department provider is only able to dispense 40 milligrams, which doesn't do a whole lot after maybe 6 or 7 hours of committing. So we have talked with some emergency departments to see if systems can be built for emergency department providers to verify a dose a patient received while on Rikers and to dispense that correct dose. Some conversations have gone further than others, but one seems a bit promising at the moment. Another opportunity is whether opioid treatment programs can just have better support and resources to create more of a bridge-like model so that the same resources and staffing that they have available Monday through Friday can be expanded to the weekend. Last opportunity, pretty recently in the last year or so, we've seen the use of mobile methadone units, which are basically just mobile satellite clinics. It's a van with a safe and medication and staff that dispense the medication that operate under a license for another community-based opioid treatment program. These have been an absolute godsend when it comes to connecting patients with residential treatment programs, because those historically have had some trouble coordinating around medications like methadone when they themselves don't have a license to dispense it. So they rely pretty heavily on these mobile units, and that works great. The main barrier we still see is that mobile units only able to provide medication when it's known in advance that somebody's going to need it and when it's sort of coordinated. So we really don't have that capacity again for people who are released on Friday or late at night or at times when they might be able to use this service, but because it wasn't known in advance, they don't have that option. So moving forward, our job at KEEP, to put it simply, is to really provide evidence-based, life-saving treatment options for people who are in really vulnerable and challenging positions while they're incarcerated on Rikers, and in that immediate post-release period when people tend to be, again, at their most vulnerable and at their very high needs of connected services. But there are key challenges, which are mostly unpredictable jail releases and systems that can be pretty fragmented in terms of how collaboration and communication happens. The solutions and opportunities really involve changes to correctional community systems so we can improve the immediate response and better support patients as they make these transitions out of the jail setting. That's it for me. Now, thank you.
And really quick before you go, Mervin, just if you have any questions, make sure you scan the QR code on the back of your handout, and then I can add those towards the end of the panel. And
yes, thank you.
Thank you. Good afternoon.
I usually don't have a problem with microphone. Good afternoon, everyone. My name is Mervin Otero. I am the program manager for a small program at the Osborne Association, which is a very large organization that's been around since 1933. The program that I coordinate is a program called the Criminal Health Initiative, which is a program that is sponsored by the New York State Department of Health. And what we actually do is we provide basically intensive case management for men and women who are incarcerated in the New York State prison system who have HIV or hepatitis C. The program has been expanding to other factors because we're starting to see that there's a lot of other issues besides HIV and hepatitis C that need attention. One of them also being mental health. The program is usually used for men and women that have 90 days or less to return home to society. So what we do is we have what we call an in-facility linkage facilitator or in-facility linkage person, and that person will go into the facility and do an intensive intake. The intake is probably like 14 pages long. So we get to learn from their drug history all the way down to how many children they have, where they plan to return into society. With that, we create a care plan to prepare the individual to return back home. The plan is shared with either someone, if they're going, for example, to the Bronx, then it's shared within the agency because the Osborne Association oversees individuals coming home to the Bronx. If they're going to another county in New York State, then the Department of Health has contracted 9 other agencies that are distributed through the state of New York that do the same work that we do. And one of those agencies would take on the case and we will do the handoff to that agency to provide the services in their community. So we can make sure that whatever needs were identified while they were incarcerated are fulfilled once the person returns back to the community. The other piece that we provide is what we call health services or education in the prison system. So we go into the prison system and we provide education about HIV, STIs, diabetes, and everything else that could be related to somebody in prison. We try to break a lot of the myths that are happening in prison that we're going to speak maybe a little bit later on that cause conflicts with individuals getting care in the prison or when they return home. If you look at this map, we are assigned 3 correctional facilities in what they call the New York City hub area. The Department of Corrections in New York State divided the state into different hubs. If you look at the lower part where it's like a square type circle on the edge, that is our area. That area has 3 state prisons. One is Queensboro Correctional Facility, one is Edgecombe Residential Treatment Facility, and the other one is Sing Sing Correctional Facility. And like I mentioned previously, if the individual is returning back to the Bronx, then we would do the case management also in the Bronx. The team is a small team, like I mentioned earlier also, is led by Laura Romes, who's the Vice President of Prison Services, and she oversees multiple other prison services teams. For example, we have a team that is called the Reentry Works. That team focuses on anybody coming from a state facility going back to New York City, and they try to address whatever needs the individual might need when they're returning back to New York City. So she's my supervisor. I have 2 individuals that work under me, one who's here with me today, Collins Absalon, and I also have Mir Neighbors, who is my in-facility person, but I also supervise a team of peers inside the prison. What we do is we prepare men inside the prison to do the same work that we do so they can educate other prisoners. Because using peers makes a better connection with getting the message out to the population. Some of our major goals is addressing the health disparities and the inequalities that are happening inside the prisons. As we know, is a captive population. They don't have a lot of choices where they're going to go see a provider. It's not like, I don't like the services at Montefiore, so I'm going somewhere else. Services have to be provided in one place. We also facilitate access, helping them get access to the services that they need. We offer tools and support to help them manage whatever conditions they're going through, whatever diagnosis, especially education or whatever they've been diagnosed with, so they know how to speak with their doctors, what they need to ask. We offer HIV, STI, hepatitis C peer training, education, and support at the facilities. And we also increase awareness about treatment and the importance of prevention treatments inside the prison. So individuals know that once they return home, they also have options, and maybe they don't have to get infected with a disease that they're going to have to treat later on. The other things that we do is we also enhance sexual health and HIV education efforts, while also assisting the linkage, of HIV testing, sexually transmitted diseases, and hepatitis C screening, so individuals can learn their status while they're still incarcerated and don't have to wait till they come home and then they're busy trying to catch up with life and not knowing their status. We deal with the different trauma-informed approaches, and we also promote the collaboration between the facilities and the agencies that we're working with. And we also try to expand our services to individuals that are incarcerated and individuals that are returning back to the community, connected them to also preventive service so they can have everything they need at any point where they're identified to have any type of need. And
Thank you. And Trevor?
Good morning. All right. Good afternoon, rather. Good afternoon, everyone. My name is Trevor Cummings. I'm a senior program manager with the New York City Health Justice Network, and I've been assisting the justice impacted population for over about 5 to 6 years now. And this is a very important and passionate topic to me because I just recently celebrated early this year my 11th year being home from prison, and I know what, how profound, support can be and what support can do for individuals who are, transitioning back into the community. And I'm here today because, an organization took a chance on me, an individual with lived experience, to, provide cultural competence services to individuals who are also justice impacted. So a little bit about New York City Health Justice Network. We are overseen by the Department of Mental Health and Hygiene. We sit in the Bureau of Health Promotion for justice impacted populations. And since 2019, our aim and our program aim has been to support individuals who are returning to the community, and by addressing, reintegration and healthcare priorities. And I say priorities because a lot of individuals have needs, but I heard a lot of talk up here about having a person-centered approach. And, while individuals have needs, they also have priorities. And we don't want to, and we want to help them address those priorities because I believe that individuals know what they need to be successful. So our approach is really person-centered. Our services are voluntary, and we also use a trauma and resilience informed approach, understanding that prison can be a traumatic experience for many individuals, and just being able to navigate prison and make it home shows that individuals are resilient and that, they do have skills, and we want to, work with them from that skills-based approach. One, I think, great thing about our New York City Health Justice Network is that while we are overseen by the Department of Health and Mental Hygiene, we are actually in the community. And we look at the New York City Health Justice Network as a public health community partnership model, where we have individuals who have lived experience, trained to perform community health workers, trained to be community health workers. So while their lived experience is an important, aspect of their role, these individuals really have the skills and are really passionate about, bringing culturally competent care and services to the justice impacted population. We currently are partnered with two federally qualified health centers, Community Healthcare Network and the Institute of Family Health. And, we partner with them to really, and we have the CHWs embedded at those locations to really have a strong understanding of the organization that they are at, the organization's culture, and be able to expedite our participants' connections to healthcare services as they are, reintegrating and back into the community. And we also partnered with Osborne and the Center for Justice Innovation, which have a long history of, providing services to this community as well. And it's been a great partnership so far. Again, our key features is that, we have those community health workers with lived experience who have navigated their own reintegration and is able to not only provide hope, but also kind of provide a way forward for many individuals who are returning back into the community. So, thank you. We really believe in empowering and supporting our participants, and helping them to achieve their individual goals. I think, while many individuals who are justice impacted do have similar goals or similar needs and barriers, our stories are, very unique to that individual. And it's important to not only recognize the kind of overall themes that the community have, but also recognize individuals for who they are and some of the barriers that may be present for them that aren't present for others. We really have a health-focused lens, understanding that there are many often overlooked health outcomes that are associated to incarceration, such as asthma, high blood pressure, hypertension, and these health conditions often go overlooked. And I know there's a question about stigma, and we'll talk about that. I'll get into that a little bit later on why some of these health outcomes are often overlooked. And then some of the services we provide is connections to primary health care, mental health services, and any specialty healthcare. A lot of our work has been assisting participants with vital documents and ID procurement, as that is something that we find to be a huge barrier for individuals that are returning to the community and with hopes of reintegration. And then last I'll say about our criteria is that we really have an inclusive criteria. There's no restrictions based on conviction type, health status, legal status. We are here to, just provide services and hopefully, help individuals as they do reintegrate into New York City. And we work with New York City residents that are 18 years of age or older and have been released within the past 3 years. And our community health workers reach out to collaborate with our participants, again, to address those healthcare and reintegration barriers that they would like to work on. And that, I think, helps empower our participants, as a lot of individuals who are justice impacted often have mandates where they aren't really given the opportunity to make decisions for themselves. So part of that process to increase their agency and self-determination is to have a program that's completely voluntary, that they can choose what they want to work on. And, they have individuals who come from similar backgrounds and often are the demographic mirror to our population and connecting them to services. And again, thank you all for having me.
All right, so I'm gonna kick off my questions with a general question is first, so if anyone wants to chime in, they can answer. And Mervin and Trevor, you hinted at one of my questions on how the stigmas, both in the carceral institution and in healthcare systems, impact the ability of incarcerated individuals to access the care they need. So anyone, when you want, you can chime.
So I'll take it. So yes, stigma. I think stigma is a large thing. Stigma. When we talk about individuals that are incarcerated and carceral settings, we have stigma that is from the staff who is kind of responsible for ensuring our protection and making sure that we can access healthcare. And then there's stigma that is kind of associated amongst the prison population. But in terms of stigma, I can speak about myself. One time when I was incarcerated, and I'm asthmatic, and I travel with my asthma pump everywhere I go, and it's always been like this. But I was experiencing an asthma attack, acute asthma attack, and I went to the correctional officer and mentioned that, hey, I'm having a medical emergency and I need to seek medical attention. And the officer was really lax in their response to contact any medical professional. And I think that was due to stigma, because I've also seen other individuals who are in these carceral settings seek medical assistance and have been denied because correctional officers, they are the gatekeeper to everything when you are incarcerated. Then we also have stigma amongst ourselves as individuals. Again, from my experience of being incarcerated, and individuals who have mental health challenges, they are also often kind of ridiculed for seeking treatment. If you've been incarcerated and they'll line at 7:30, and they'll say, hey, this individual is 7:30, kind of insinuating that the individual is crazy. So that also impacts the individual's ability to go voluntarily to seek treatment, which again is all kind of related to stigma. So I think society, it's a real society issue, how we view individuals who have medical issues or mental health issues and are seeking treatment. So until we as a society get to a place where we recognize that mental health challenges is normal, and we can normalize that and normalize individuals seeking service without fear of being ridiculed or being chastised, and stigma will always have a significant role in individuals' apprehension to engage with care or access care.
I'd like to add a couple things. One thing I agree 100% with the stigma of mental health, which is a major one. In society, we're starting to see that people are getting more open with mental health. In prison, they're decades behind, and your own peers don't help much in the prison system, because like it was mentioned, an individual that is seeking help for mental health is immediately classified as being crazy or as being weak. You can't handle the pressure of being in prison, you're breaking down. And these things don't help getting attention in the prison system. Other things that are very important, things simply like just being HIV or seeking 50 and over, seeking to get a colonoscopy. Immediately you'll have the stigma where people saying, Or you're gonna go get a colonoscopy. What are you? You gay or something? And make people not want to take care of themselves like they should be taking care. And on the theme of gender, the stigma of the Department of Corrections having minimal trainings for staff to understand some of the changes that we're seeing in the population. And when we see individuals that are disclosing their gender identity in a different way, they're immediately stigmatized. So they're not seeking care, because if they disclose, their care is immediately criticized and is put down. So stigma is real in the prison system, and it's something that needs to be addressed immediately.
I'll add to this from my very specific and narrow focus of people who receive medications for opioid use, because I think there's still a lot of stigma around this. I will say in the last few years, I've seen there have been tremendous movements made by providers, by programs, by OASAS, by SAMHSA, to educate around what these medications are, what the benefits are, how life-saving they are. And it's changed the landscape, but there is still stigma present. There are still providers who hold on to some of it, whether they mean to or not. From my own experience, I started as a clinician with Correctional Health Services in 2017 and came in without any prior knowledge of medication for opioid use disorder. And with all of the best intentions, probably perpetuated some stigma myself, and it's one of those things where if you don't have the education and the background, that potential is there as a treatment provider to perpetuate that. But one of the things our team also sees quite a bit, I think, is patients and people who use these medications often internalize the stigma themselves. We have people who may be incarcerated on Rikers, receiving methadone, receiving buprenorphine, stable on it for months, doing really well, and then a month before known release date, come to our team and say, hey, I want to be off this now. I want to be clean. I don't want to use drugs anymore, because they've learned over the years that the medication they're prescribed is a drug and that it doesn't count as being in recovery because they're still on this. Or because they're worried about what their spouse or what their kids or what their grandma or somebody's going to think of them receiving this medication. So obviously that's, a huge challenge for us, but also a huge opportunity to really provide education and process those decisions so people don't set themselves up for failure at that really critical and really vulnerable time. So, I am hopeful. I have seen a lot of change happen and a lot of improvements happen, but the stigma is still there, and it comes from a lot of sources, and it's something we all need to be aware of.
So I want to take a couple of moments to talk about how we can see the stigma that was described actually entrenched in policy and the policies and procedures related to health services and opioid use treatment in the state prisons. So one thing that we've noted, we actually have a report coming out tomorrow on the implementation of MAT in state prisons. But one thing noted in that report is the reliance of the department on sort of abstinence-based treatment programs, and specifically the ASAP, the Alcohol and Substance Abuse Treatment Program that's offered in state prisons. So, right, you have the MAT program that offers a medication-assisted approach for treatment for substance use disorders, and on the other side, you have a course that people have to take or assigned to. Oftentimes need to take that course in order to be eligible for release for CR day or for a parole board interview. And that course being based on abstinence, not on a treatment based perspective. We went to Hale Creek, which is a state prison that's generally focused on preparing people for reentry and release, and spoke with the health services staff there. And they spoke about how individuals who are enrolled in the MAT program or individuals who are seeking to enroll in the MAT program will hesitate to make their needs known to a healthcare provider because of a fear that they might be removed from the alcohol and substance abuse treatment program, which is required for right of CR date or release. So, right, the policy right there is forcing folks to make a choice on, am I going to subscribe to a stigma-based model or am I going to subscribe to a treatment-based model? And oftentimes, right, people are prioritizing that date of release over treatment. So one other thing I want to note is just going back to this idea of right healthcare in prisons being not part of the public health sphere. So currently under state law, and I mean, thankfully, right, in New York City, it's a little different where you have New York City Health and Hospitals able to, right, operate health services within the city jails. On the state level, you have health oversight from the State Department of Health that's limited to, by law, to HIV, hepatitis C, and COVID-19. So one, that lays out that, right, something is only under the purview of the Department of Health if it is an infectious disease, because there's this subsequent threat to the larger public, but it doesn't really grasp that, like, overall, the people who are incarcerated in state prisons are part of the larger public and should have access to, right, the Department of Health review of health policies at large. So what ends up happening in state prisons is you have decisions about health going through a security-minded perspective. And, right, because at the end of the day, there's the top, right, the commissioner who oversees the, right, deputy commissioner on health services is responsible for the security of the system and not for the health care not for the health of the people in state prisons. So, right, one, there is, right, there's legislation out there that would expand the Department of Health's ability to provide an overview and, right, dictate health policy in state prisons that's languished for, you know, years now, to be transparent. It has been amended down to, right, have it address COVID-19, but not the larger health needs and not the larger health policies that are affecting people's access to healthcare in prisons. I'll share an example of how that could come into play, specifically around the use of opioid use treatment in state prisons, in the sense that something you'll hear or something that we've heard through our monitoring is a reliance on a Sublocade or injectables over oral-based medication for opioid use treatment. And the thinking around that is based on this idea of trying to prevent diversion over trying to provide the best medication for the individual in need. So, and then on that piece, right, if there is this idea around diversion, wouldn't that point out that there are other individuals that could benefit from being in an opioid use treatment program, right? So rather than reaching out to those folks and figuring out, like, right, what those folks' needs are, right, it's a disciplinary-based approach where, right, there was someone who diverted something and they're going to be subject to, right, a disciplinary ticket and the consequences of that disciplinary ticket. But just wanted to, like, take a couple of moments to talk about how, like, what we're describing here, right, and the stigma that you see maybe on the ground and among people is, in a sense, entrenched in policy too, which is something that we should talk about.
Yes, thank you. And going off of what you just said, I want to ask those who work statewide the differences you may see in state facilities versus New York City programs that they might have, and how do these differences impact the ability to address health disparities?
Since I was I've been speaking for a while, so break, but yeah, happy to.
I'll mention, for me, it's a double-edged sword. And I say that because I focus more on state correctional facilities than city facilities, and it can work both ways. My belief is that in the New York City jails, individuals sometimes are not there long enough to get the appropriate attention that they need. Sometimes their stays might be so short that they don't even realize that they have certain conditions or enough time to start a treatment, like for example, for hepatitis C, and complete the treatment before they're released. So in the state system, it might have some benefits because they're there for longer terms and they're able to identify some of the conditions they have and have the time period to address those conditions they have. But the reason I say it's a double-edged sword, because then on the other side, someone that is in a New York City jail will be returning home soon and might have options to different treatments versus somebody in a state correctional facility that might not have that option, might have been diagnosed with a cancer, but doesn't have the option to select which provider they want to see. If they want to see a specialist at a particular hospital, that's not a choice. You have cancer, you're going to get diagnosed. We're going to send you when there's time to a specialty place where they can start the treatment, and that is your option. So there are pros and cons on both sides. And I think the biggest challenges is for the city, not enough time for treatment. And then the state, the challenge becoming the options are very limited for the treatments that individuals are going to get.
Thank you. Thank you. Thank you. There we go. Thank you. So no, I agree. I think on the state level, right, there is this limited availability, limited options for healthcare at large. Right. I want to talk a little bit about like where these prisons are and why they were built in these areas. So I mean, right, there's this general conception that prisons have always existed. They came into existence in New York and Pennsylvania. Right, the Auburn system, this idea around building Sing Sing, building Clinton, building Auburn. Auburn's the oldest operating prison in North America, by the way. Far away from population centers, right, was a choice to move people away from population centers as this idea to isolate folks, this idea around penance. So, right, we're looking at prisons that were built in the 1800s and dealing with the consequences of those prisons being in the locations where they are today. So one thing, like we have the staffing data up on our website publicly, but as of January 2024, docs reported a 25% vacancy rate across health services, filled positions system-wide, meaning that, right, like 1 out of 4 positions are vacant system-wide. How does, right, having proximity to New York City, to the Osborne Association, to community-based providers, to peer support services in different population centers of the state, how does that affect the ability of, right, state prisons to, right, not only like fill health staffing levels, but then bring in community-based providers to fill those gaps, right, and in different parts of the state. So you look at vacancy rates for some of the North Country prisons, and they might be almost full on security or full on security staff, but then you're seeing these large vacancies around health services, around program services. So just want to talk a little bit about, right, that being part of the calculus and the distance from how far people are and the distance from how far these prisons are to being able to recruit to fill these positions has an effect on the level of care that people are receiving in these faraway places.
Thank you. And I want to then pivot into our reentry programs that we have on the stage. What are the most critical factors in ensuring successful care transitions for individuals reentering the community? You might have touched on this in your presentation.
I go. So one critical factor I believe is prevalent and needs to be addressed is currently, and I believe New York State is one of the better states across the country in terms of Medicaid reactivation once a person is released from incarceration. However, there are still many individuals in New York State that when they are released, their Medicaid isn't active, right? So as a New York State health, New York State Health Assistant, I've been connecting individuals to health insurance. And one thing that I do notice is that when you are completing the application for health insurance on the marketplace, you often need identifying documents to support who you are. I think everyone, I don't know, got his name, I'm sorry, Mike, he mentioned that, participants that prisoners are released without vital documents. And that's a huge barrier because with New York State Health, they do allow you 30 days to, have insurance or coverage, but you have to submit those documents before your insurance is terminated. So it presents another issue around, ID procurement, which again, if an individual don't have their birth certificate, don't have their social security, our program has to really think outside of the box on how we can acquire or gather necessary documents to get the individual their ID and then have that information, relayed to New York State of Health. And that continues to be one of the leading causes for individuals not really connecting in care when they are released. And another issue is there is a huge provider shortage. I work inside of one of our clinical partners, and the medical staff is often overbooked, and that is that impacts patient care and how patients are received by the providers. And when we talk about a population that has been historically impacted by the healthcare system, it's important that we are connecting individuals to affirming culturally competent and comprehensive care. And that's something that I think our healthcare system isn't geared to do and don't have the capabilities to support kind of throughout the whole healthcare system currently.
And I'll add to this. Again, I may focus a little narrowly on patients with opioid use and receiving medications, just because that's my own background. But there are, I think, a few sort of pillars for successful reentry planning. And, I appreciated Dr. Wright's distinction between reentry and reintegration, because I think a lot of times we are focusing really just on reentry, really just on that very immediate, like, hey, you just hit the street. You got a couple of days. How do we situate you with everything you need? So I do realize I'm focusing on that. But so I think one sort of pillar is education. There's a couple of things around this. First, it's educating people who are receiving healthcare services, who are receiving medications, having really honest and upfront, direct conversations about these are the barriers that exist, and this is what you may face, and these are some potential workarounds, and having as much of that sort of ironed out as you can. But I think that education also falls on community providers as well. Here in New York City, we're in a really unique situation where for opioid treatment specifically, because KEEP has been around for 30 years, there's this infrastructure in place. Every program in New York City knows what KEEP is, knows if you just came from Rikers, this is what we need to do for you, and we'll do this as quickly as we can. But but I get the feeling that in other places in this country that doesn't exist at all. So really expanding that education that treatment providers have in terms of what it is that people need when they come out of these systems and these settings. Collaboration, I think, is another big part of this. People who are incarcerated and are being released on ATIs usually have very little of their own say in terms of what their healthcare is going to look like and what their treatment programming is going to look like. And there's a whole team of people that are responsible for coordinating that and collaborating to make sure that happens. There's a very quick story and anecdote. A couple of years ago, I worked with a person who was released from Rikers, was receiving methadone, and was released on electronic monitoring. And no planning had been made beforehand around methadone treatment. So now he's kind of stuck at home, needing to go to an opioid treatment program multiple days a week and has no way to do this. I'm sending emails to 15 different programs saying, hey, I've got this patient, don't know if or when you'll ever be able to see them, but could we get them some medication, please? And we did get that worked out. A social worker had to go to the program and navigate security of the program and pick up the medication, bring it on the train and bring it to the patient. I bring that up because that's actually a system that for my work has been fixed since then. I no longer see that happening now. I do see that there's more communication happening with KEEP and with the courts and with everybody involved to make sure that if somebody's being released in that situation, care is coordinated beforehand. But again, that responsibility really does fall on all of these other stakeholders, sometimes more than the person who needs the services, needs the treatment. And I think the very last thing I'll mention is just always maintaining this continuous focus on reducing barriers and addressing the barriers that exist. One of the interesting things about healthcare in a place like the New York City jails is there are certain barriers that exist in the community that don't exist in that space. You don't have to travel to a program. All of your services, unless you're receiving acute care in a hospital setting, are going to be inside the jail in one location. You don't have to go to 2 or 3 different programs or providers to receive the services you need. If you don't have insurance, if you don't have documentation, you're still going to get care. You're still going to receive medication. You'll still receive services. Once you're released, that becomes a bit dicey. And there have been a lot of changes specifically around opioid use on disorder medications on the community side. There are federal regulations that changed this year that now allow for more flexibility in terms of how take-home doses are dispensed and how many on-site visits are needed, and that allow for patient-centered and personalized treatment planning versus just taking this one very broad approach to every single person that comes in. There's also more flexibility around telehealth and teleprescribing for buprenorphine. So barriers are being reduced little by little, but that is definitely a conversation and issue that still needs to happen.
Yes, thank you. And now we're going to move to Q&A from the audience for the last 10 minutes, and then we'll get you guys to lunch. So one question we have that is for general for anyone: what are the real-time challenges that you are currently seeing happening in your program?
I can speak about a lot of different challenges. I think one of the major challenges that we're having was mentioned in the first panel that they had, which is housing. We have individuals being released from the city jails or the state system, especially when you had an individual in the state correctional facility for 15, 20, 25 years, and you're releasing them and they have nowhere to go but the shelter system. That if anybody here who has never visited a shelter, I tell you, you should. I make it my business as a program manager to visit the places where I would send people. And some of these places, I am traumatized myself. So we send individuals to these places that are horrible for survival. And now we're expecting them also to thrive with their medical care in a place where most people would not even want to be there. I think that's one challenge. The other major problem was mentioned by my colleague when he spoke about problems with identifications, basic things. You get an individual gets arrested with an alias. So his alias is Toni Rivera, while his real name is John Rivera. Now he's released. They know his real name is John Rivera, but he's being released with all this paperwork that says Toni Rivera because that was the name he was incarcerated under. And now the challenge for him to get birth certificate, any type of New York State ID, all of that, and all of that is going to run into other problems with him getting medical insurance, getting housing services. Everything else is going to be a nightmare from there on. But and the third point I think is a challenge is that individuals are not being prepared for release, like you mentioned, way in advance. So individuals are being prepared for release 90 days. You've been incarcerated for 25 years, but we're going to prepare you in 90 days to return back to society. Ridiculous. And I think these are some of the issues that we need to address.
Yes, I agree. Housing continues to be an issue. And I work with participants and they were, had housing insecurities. And I've offered them, hey, we could see you referral to a shelter. And I was surprised at how many individuals would be like, no, I don't want to go to the shelter. And it wasn't until I actually had to go visit a participant at a shelter and I seen some of the conditions that they were living in. And it's sad that an individual would say, hey, I don't want to go to the shelter. I prefer to just be street homeless because the shelter is so, poorly, ran. And along with employment being an issue, just this year, around 80% of our participants report being unemployed. So when you are facing housing insecurities, unemployment, unless you have like severe health conditions, you probably are very unlikely to go to the doctor, because you worry about where you're going to sleep or where your next meal is going to come from. And the doctor can't help you with that, right? The doctor, they can't help you with that. And, those going through that can be very stressful. And we also know the impacts of stress and how they exacerbate, health conditions. So this is, a real issue, but I'm glad to be in a room with all y'all forward thinkers and how we're going to address these through policy and through program implementation. Yeah. But it is a struggle for many individuals to fully commit themselves to engaging with healthcare services when they have so many other priority needs that aren't being addressed.
Good stuff. Thank you. Another question circles back to our discussion about stigmas. The question is, a stigma is not likely to disappear completely from the system that justice-involved populations interact with. How can programs prepare individuals to meet the stigmas they encounter without compromising their recovery and productive engagement within their communities?
I want you to answer.
I was hoping Mervin would actually speak a little bit about one thing that's a policy recommendation for the Correctional Association should be just to increase the availability of peer-based programming in prisons. And happy, we were on the same page. Yeah, I mean, having people who are closest to the experience and closest to the issue approach other folks who are struggling with the same sort of needs is critical in addressing stigma, right? Having a trusted person who could speak to why maybe a treatment-based approach or health needs should be looked at directly could go a long way. So, having folks who are peers, folks who are community-based providers, just different people outside of the security focused system in the state that's in place could go a long way.
And I just want to say that, as clinicians, I think we have a lot of responsibility and a lot of tools to address stigma. A lot of times this does involve working directly with people who have internalized stigma and may be presenting with that without realizing it, looking at words that they use and looking at the ways that they define themselves, the ways they define certain concepts, even if it is just very simple things like addressing terminology, talking about a dirty urine instead of a urine toxicology that came back positive for a certain substance. And I think part of that also falls on us to always be mindful of how we present and the language we use and the terms we use and what we're putting out there. Again, bringing this back to opioid use, bringing this back to methadone specifically. You know, a lot of times we work with patients who choose to lower a dose or come off of the treatment. And if it were a different medication, a person might say, oh, you're tapering off the medication. Or with methadone, they say, oh, we'll detox you off of this, with that implication that, oh, it's a drug. You know, there's so much like loaded terminology and so many ideas that we sometimes put out there without realizing it. So I think that's something that really does fall a lot on, again, on us as treatment providers to be mindful of, to help address.
I'd just like to add in terms of how we address stigma. I was raised on each one, teach one. So I'm a real, like, you know, I feel like things happen at the community level. So I asked everyone in this room, how do you go back to your own community and address stigma? So one thing I like to do, again, as an individual, I'm from the Bronx. And I like to, I've just got comfortable with engaging in mental health services. After many people in my family kind of encouraging me to do it, post-incarceration. So one thing I do like to do is educate the youth around, the benefits of mental health education, because stigma is something that, around mental health services is something that's learned at a very young age. Yeah. At a very young age, from people who we love, that we hold dear to our hearts. So it's really about, I feel, educating the youth and educating, communities to, reduce the stigma in their community. And I think that'll eventually, spread to the rest of the world.
Well, that's all the time we have for this panel. I want to thank you all for joining us. This was such an engaging conversation about jails and healthcare they have there. And now we'll be transitioning over to lunch. If you're online, you can either stay or come back. We'll be back at 2:15 for our third and final panel. Thank you very much, everyone.